इसीलिए बोला मैं। ये रूटीन सारे सब एक जैसे दिखते हैं, नहीं तो वाइट वाइट।
We are live.
Good evening, everyone. On behalf of ARC AIOS, I warmly welcome you all to our webinar on diabetic retinopathy, essential pearls for everyday practice. It is my absolute pleasure to welcome our distinguished chairpersons, our panelists, our speakers, and most of all, the audience that is with us today this evening. As you know, India has the dubious distinction of being the diabetic capital of the world, and we all see every day, and we will continue to see more and more patients of diabetic retinopathy in our practices. Still, there are a lot of challenges that we face in our everyday practice. The first challenge is to identify the disease early on in its course so that we can manage it appropriately. The second challenge is the variety of presentations that diabetic retinopathy can have. And sometimes it becomes really challenging to how to manage the patients. We have such a big armamentarium of lasers, injections, surgeries with us. And the challenge remains as to which treatment modality to tailor to the patient. Another challenge is to keep abreast with the ever increasing diagnostic modalities, the OCT, angiography, AI now, to keep abreast with those and integrate them into our practice. And another challenge would be to work in close cooperation with the diabetologist, the nephrologist, and the other physicians who are managing the patient. So all these challenges still remain with us, and sometimes it becomes a very complex problem as to how to handle and manage these patients. So today we have a very expert panel of speakers who will be giving us some pearls on how to manage diabetic retinopathy in our day-to-day practice, and I welcome them all to this webinar. It's also a very good fortune to have with us a very distinguished panel of chairpersons. And it is my pleasure to introduce our chairpersons before we begin the webinar. So we have with us Dr. Lalit Verma, someone we all know and look up to. Sir is the director of the Vitro Retina Services at the Center for Sight, New Delhi. With a very distinguished academic background, he has decades of experience in managing retinal disorders, and he has mentored countless retina specialists who are practicing today. He is a source of inspiration for all of us. He's been the former president of AIOS and has held numerous leadership positions in various national and international societies. And he's also the Congress president of the forthcoming APAO conference in New Delhi. So welcome, sir. It's really a pleasure to have you with us
It's
this
my
evening.
pleasure.
Our second chairperson is Dr. Muna Bhinde. We all know her equally well. She's a renowned vitreoretina surgeon who is a senior consultant and deputy director of the VR services at Shankar Nethralaya, Chennai. Beyond her clinical expertise, she is deeply involved in research, publications, and she's at the forefront of education. She has mentored and trained so many fellows who have worked under her. She also has a special interest in medical retina, inherited retinal disorders, imaging, and also diabetic retinopathy. I've heard some wonderful talks of hers on diabetic retinopathy. So welcome, ma'am. We are looking forward to all your inputs and insights into this diabetic retinopathy. We are also honored to have with us Dr. Sandeep Saxena, who's the professor and chief of retina services at the King George's Medical University, a keen academician, a teacher, a mentor, a translational researcher, and an excellent clinician. He has recently published a 9-part series of an atlas of retinal diseases. His research has highlighted several molecular and imaging biomarkers for diabetic retinopathy. He's also published a classification for diabetic macular edema and also a book on diabetic macular edema. And fortunately, he's also been my teacher during my post-graduation. So a very warm welcome to you, sir.
Thank you.
We are extremely fortunate to have such a galaxy of chairpersons to guide today's discussion and share their wealth of knowledge with us. So with that, we'll move on to our first talk. Before we begin, I encourage the audience to please keep your questions coming. This is a very good opportunity to get all your doubts cleared. We have a chat box. This session is also live on Facebook and YouTube, so you can post your questions and comments there as well. So with that, let us dive into this session. And our first speaker is Dr. Chaitra Jaydev. Dr. Chaitra is the head of the Vitreoretina Services at Narayan Nethralaya, Bangalore. She's also the treasurer of the Vitreoretinal Society of India and the secretary of the Karnataka Ophthalmic Society. So she will be giving us an introduction to diabetic retinopathy, and she'll be talking about the basic tenets of diabetic retinopathy management. So over to you, Dr. Chaitra. Looking forward to your talk.
Thank you so much, Tinku, for this opportunity, and to the team ARC. I think it's a very pertinent topic, given the fact that, like you mentioned, India is the diabetic capital. And very often in our clinics, we see patients, very young patients, coming in with a picture like this. And for the audience, this is how we should normally be looking at the retina in a young patient. We also see patients coming in with macular edema. You can see hard exudates. Vision is, quite badly affected in these patients, and gross neovascularization, as you can see in this patient. So today I'm going to speak briefly about the diabetic retinopathy management principles. Won't be going into detail, just a quick overview. No financial disclosures. So like I said, I'll be giving an overview of the epidemiology, risk factors, screening, ways to screen, just one slide on treatment, and then finally the summary. So the diabetic disease burden is huge. If you look at this particular slide, it tells that more people have died from diabetes when compared to other infective diseases all put together, whether it is HIV or tuberculosis or malaria. So it is like the newest epidemic that we have. Next, when we look at the worldwide changes itself, you can see how much we are heading towards, the millions of cases that we are heading towards. If you see in 2019 and compare it to 2045, you can see the percentage increase. And let's just look at Southeast Asia that concerns us the most. We're expecting a 74% increase in the number of diabetics, which is really, really alarming. Now, when you come to the prevalence of diabetic retinopathy in India itself, we have not too many population-based studies, but what it shows is that the prevalence of diabetic retinopathy is anywhere between 20 to 28% on the basis of these few studies that we have. So when you look at our population itself, 101 million Indians are already diabetics, which means 11.4% of the country's population are already diagnosed with the condition. The average age of onset is so low. It's just at 42 years, patients are already developing. This is just the average age. Nearly 1 million Indians die due to diabetes every year, and it's projected to be home to 109. But going by the rate that we are seeing now, I think this is going to be a much, much huger number by 2035. Why is it that we're seeing such large numbers? Well, we are genetically susceptible, high calorie diet, and a low activity lifestyle compared to the Western population. Now, going a little bit more into what about diabetic retinopathy itself, it's one of the major complications of diabetes. And you see either in type 1 or type 2, where there is elevated blood glucose, blood pressure, and other risk factors. Most importantly, you see microvascular complications, which is damage to the small blood vessels. Of course, there are a lot of other comorbidities that are associated with diabetes. Loss of vision is one of the most feared complications. When you ask patients about, what they felt at diagnosis, 63% of them felt that yes, their health may be affected. Only 25% of them were devastated, and 9% were not really concerned. But what they were most concerned as far as the complication go, nearly half of them were problems associated with vision or loss of vision itself. Of course, the rest had other concerns. Now, when you look at the number of diabetics currently and those are heading towards diabetes by 2040, you can see 35% of them have some form of diabetic retinopathy, and 45 million have vision-threatening DR, which could be either PDR or it could be diabetic macular edema. So what are the risk factors? We are all aware of modifiable risk factors and non-modifiable risk factors, but the two single most important ones are HbA1c and the duration of diabetes that have the most influence on the prevalence of DME and, for that matter, DR as well. Now, what is also important is that diabetic retinopathy itself is a risk factors for cardiovascular diseases. It could be coronary, it could be strokes, heart failures, and cardiovascular mortality. So when we diagnose these patients with diabetic retinopathy, it becomes very important that we send them across for a detailed evaluation. Now, the presence of retinopathy of any grade more than doubled the risk of cardiovascular disease in type 2 patients and made it 4 times in patients with type 1 diabetes. This is what we need to impress upon our patients. So we need to look at the larger picture and make sure they are holistically treated. Of course, clinical presentation, I'm sure somebody will be covering, but it's broadly categorized into non-proliferative and proliferative. And 25% of patients have PDR at 15 years of diabetes duration. That is again something that we need to warn our patients that if they don't keep their sugars under control in another 10 to 15 years, they're going to develop advanced diabetic retinopathy. Now, for diagnosis, again, a quick overview: FFA, OCT, OCTA, wide field imaging, and B-scan. Wide field FFA, you can see beautifully shows, leakage when we are doing dye-based angiography. OCT is an excellent tool. This is two eyes of the same patient, and you can see the difference in treatment. Both of them receive the same both eyes receive the same treatment, but one eye responded and the other didn't. So you see, it's so important that we see beyond just the imaging or the clinical picture, go more deeply into biomarkers as such. Octa is non-invasive. You can even see neovascularization quite clearly on Octa. And wide field imaging, this is the image that I showed you in the first slide. Of course, when media haze is there, you would need ultrasonography to look at vitreous hemorrhage. You want to look at TRD, especially when surgical planning is there. It becomes a very, very important tool using ultrasound. Now, screening and referral criteria becomes important, especially when you're in a multi-specialty center, when you want to ask your other physicians to refer to you. Who should screen where, how, and when is important. Well, a clinician or a technician can screen. It can be either on-site or remote, and clinically or imaging. At your clinic, you can also, this is basically for people who are not very comfortable looking at the retina, non-mydriatic fundus on phone. This is the Remedio. This is costs around, I think, 3 lakhs. You also have the Zeiss. This is slightly higher. It's around 4.5 to 5 lakhs. The Trinetra Classic is also available. So these are excellent tools where you can take images and send them to someone who can help you diagnose. This is also around 3.5 lakhs. So when to start screening, periodicity of screening is available online. This is some chart that we all need to know very well, because we tend to miss out on certain high risk patients, like especially those who are pregnant, and how often that we need to screen them becomes very important. Now, coming to the treatment itself, if you suspect DR, do refer immediately if you're not a retina specialist. Treatment modalities are intravitreal agents. We have modified grid, focal, PRP, surgery. It depends on the extent of the disease or the severity. So in NPDR, we want to prevent the development or progression of the diabetic retinopathy and DME. In PDR, we at least want to maintain the vision that there is with either PRP or surgery. And with DME, of course, we want to maximize the vision gains and maintain them over a long period of time. Follow-up again, once there's already a center involving DME, we call these patients more often with or without treatment when indicated. When there is moderate, of course, the follow-up is even more closer. Of course, in proliferative diabetic retinopathy, the follow-up would be every 3 months, because we want to keep a close watch and make sure they're not developing any vitreous hemorrhage or tractional retinal detachment. Systemic control, this again is an important slide. For type 1 diabetes, it can reduce retinopathy by 76%. And the effect of good glycemic control can persist for at least 10 years. And for type 2, it can reduce the risk of progression at least by 33%. There would be early worsening that should not discourage the patient or the physician. To conclude, it is a complication of diabetes that is caused by damage to small vessels. Patients with severe NPDR, PDR, and DME require immediate referral unless you can handle it on your own. An annual eye screening from the time of diagnosis for patients is highly recommended. And treatment, of course, is multifactorial and multidisciplinary. We cannot handle these patients on our own. We do need a nephrologist, a cardiologist, a neurologist, and of course, the diabetologist. And clear communication between the diabetologist and retinologist is very essential for optimal patient care. On average of 20% of patients already have DR at diagnosis, and 78% of patients with diabetes, like I said, will have it in the next 15 years. Our comprehensive eye examinations can lead to an early diagnosis, treatment, and prevent vision loss. Thank you so much.
Thank you, Dr. Chaitra, for that excellent overview of diabetic retinopathy. It was an excellent introductory talk. So we'll have the discussion after the subsequent talk. And what I'd like to share with the audience is that in this session, we also have two very interesting debates. And we also have a section called Saransh, where Dr. Brijesh Thakkar will be discussing some very pertinent journal articles. So please watch out for those. With that, we move on to our second talk, that is by Dr. Saurabh Luthra. And Dr. Saurabh is the Director and Chief of Vitro Retina and Uvea Services at the Drishti Eye Institute, Dehradun. He's also the Chairman, Scientific Committee of the Uttarakhand State Ophthalmical Society. So Dr. Saurabh will be speaking on how to recognize diabetic retinopathy. He'll be also telling us about some important signs that we should not miss when we are seeing a diabetic patient. Over
Thank
to
you.
Doctor.
Yeah, and thank you. Can you see my slides? Should I go ahead?
Yes, they're visible.
So my job today is to just tell you about the signs of diabetic retinopathy. I won't go into the pathogenesis, but basically it's a microangiopathy and it leads to microvascular occlusion and microvascular leakage because of the loss of pericytes. These are the symptoms. We are all aware of these symptoms. Slit lamp examination is important because we don't want to miss iris neovascularization, which is actually quite silent initially and maybe a harbinger of very ominous diabetic retinopathy. And gonioscopy is also equally important. And you can see neovascularization of the iris and the angle. In the fundus, we have things like microaneurysms, which are saccular capillary dilatations, retinal hemorrhages, ERMAs, which is intraretinal microvascular abnormalities, venous caliber changes, hard exudates, and cotton wool spots. So I'll show you picture-wise. So you can see in the top left hemorrhages and microaneurysms, and in the top right, you can see some cotton wool spots here below the infratemporal arcade. And very nicely, the PDR is picked up in the bottom left, where you can see the neovascularization of the disc and also macular edema in the form of hard exudates. And in the last picture, we can see all these features again. So microaneurysms are localized saccular outpouchings and usually seen in relation to areas of capillary non-perfusion, and it is one of the earliest signs of diabetic retinopathy. They leak on fluorescein angiography. So that's another very nice way of demonstrating microaneurysms. Retinal hemorrhages, can be dot and blot, where these are deep hemorrhages, usually round or oval, or they can be flame-shaped or splinter hemorrhages, which are more superficial in the nerve fiber layer, and they're absorbed slowly after several weeks. And they may be also coexisting hypertension. So with the white arrowheads, and black arrowheads with the white arrows, these are the dot and blot hemorrhages. And on the left side, you can see these splinter hemorrhages, which are more superficial. Hard exudates are intraretinal lipid exudates. They are yellow deposits of lipid and protein within the retina. Accumulations of lipids leak from surrounding capillaries, and microaneurysms may form a succinate pattern. And hyperlipidemia may correlate with the development of hard exudates. So these are some hard exudates. Cotton wool spots are white, fluffy lesions in nerve fiber layer, result from occlusion of retinal precapillary arterioles supplying the nerve fiber layer with concomitant swelling of the local nerve fiber axons, also called soft exudates or nerve fiber layer infarctions. FFA shows no capillary perfusion in the area of the soft exudates, and they're very common in diabetic retinopathy, especially in patients with hypertension. So these are the cotton wool spots, which we can see here in the fundus. Venous beading is another feature, which is dilatation and beading of the retinal vein and appearance resembling a sausage-shaped dilatation. These are signs of severe NPDR. And IRMAs are abnormal dilated retinal capillaries. Severe NPDR in presence may indicate rapid progression to PDR. And these are intercommunications between retinal arteriole and venules, and they bypass the capillaries. They are seen near areas of capillary closure. They are intraretinal in location, do not cross major vessels, and do not leak on FFA. Diabetic maculopathy can be in the form of macular ischemia because of capillary non-perfusion, or macular edema, which may be focal or diffuse. It can be seen in both NPDR and PDR and causes visual loss. So this is how we see, macular edema clinically and in the OCT picture on the right side. So it can be focal or diffuse, where on FFA you can see focal leakage, whereas in the bottom right picture, you can see diffuse leakage on fundus fluorescein angiography. Macular ischemia, you can see that the FAZ is distorted and the ischemia is involving the foveal area. So what is CSME? It is a definition from ETDRS, retinal thickening within 500 microns of center of the fovea, or hard exudates within 500 microns of fovea if associated with adjacent retinal thickening. Retinal edema more than 1 disc diameter, any part of which is within 1 disc diameter of the center of the fovea. So this is a patient with CSME. It can be also in the form of a succinate retinopathy like here. So classification is basically NPDR and PDR. NPDR can be mild, moderate, severe, and very severe. And proliferative diabetic retinopathy can be mild to moderate, high risk, or advanced. You can see here a mild NPDR, which is indicated by the presence of at least one microaneurysm, and definition not met for moderate or severe NPDR. Moderate NPDR is hemorrhages and or microaneurysms more than standard photograph 2A or cotton wool spots, venous beading, or intraretinal microvascular anomalies. Severe NPDR is the 4-to-1 rule, where one or more of hemorrhages and microaneurysms in 4 quadrants, venous beading in at least 2 quadrants, and irmas in at least 1 quadrant. And there's a 15% risk of progression to high-risk PDR in 1 year. NPDR can also be very severe, where it is defined by the presence of any two of the following features used to define severe NPDR, and there's a 45% chance of progression to high-risk NPDR within 1 year. PDR is marked by NVD, which is retinal neovascularization occurring on the optic disc or within 1 disc diameter of the optic discs. These are some pictures of NVD in proliferative diabetic retinopathy. This is how NVD will look, where you can see these angel hair vessels within 1 disc diameter of the optic nerve head. NVE is retinal neovascularization occurring further than 1 disc diameter from the optic disc, and this you can see this profuse leakage on fundus fluorescein angiography in NVE. And this is a clinical picture of NVE along the supratemporal arcade. Proliferative diabetic retinopathy can be mild and high risk. High risk is when NVD is at least 1/4 to 1/3 disc area in extent, NVD associated with pre-retinal or vitreous hemorrhage, NVE that is at least half disc area in extent and associated with pre-retinal or vitreous hemorrhage. There's a 26% chance of severe visual loss in 2 years in untreated eyes with high-risk characteristics. That's why it's so important. Then you can have advanced diabetic eye disease, which is the final stage of uncontrolled proliferative diabetic retinopathy, where you can have glaucoma, neovascularization, and blindness. So I'll show you some pictures. So this is PDR with vitreous hemorrhage, then tractional retinal detachment with fibrovascular proliferation, and then finally rubeosis iridis and neovascular glaucoma. So what are the diagnostic tests? We can use fundus fluorescein angiography. I've been showing you some pictures. It is basically to guide treatment of CSME, probably most useful to confirm presence of macular ischemia. Nowadays, we have the OCTA for that. To differentiate irmas versus neovascularization, evaluation in hazy media. It is not a screening modality and it is not a routine investigation. So these are some FFA pictures of PDR, where you can see early and late films showing NVD. Fundus photography is very important for documentation purpose. OCT is another very useful tool. It's a non-contact, non-invasive, which shows in microns a cross-section of the retina, where you can do a qualitative analysis, where various biomarkers are there, which will be discussed later, and quantitative analysis is also possible nowadays. So this is an HD scan of the normal retina, and on the right side, you can see changes of diabetic retinopathy. Ultrasound, as Dr. Chaitra said, can be very useful when media is opaque, like in vitreous hemorrhage, to rule out a retinal detachment and also to look for a tractional retinal detachment and its attachments, and also to evaluate vitreous hemorrhage. Nowadays, wide angle, ultra wide field fundus imaging is becoming more important, because as we can see here that outside the 7 standard areas of ETDRS, you can have a lot of findings. And this is very useful nowadays for those centers which have it. You can see some pictures. And there's a concept of predominantly peripheral lesions in diabetic retinopathy, which is outside the ETDRS 7 field circles, which is predictive of DR severity and progression. OCT, as we know, is very useful. OCTA actually is a newer modality which is being used more importantly now, because you can see the vascularity and you can do a perfused capillary density mapping and changes in FAZ metrics and vessel density. These are some pictures of OCTA. And lastly, the ultra wide field NFAS OCTA like this can give you a very good picture akin to a fundus fluorescein angiography montage with one single shot. So this is my last slide. So AI is coming in diabetic retinopathy also, and there are several FDA-approved AI-based technologies. I won't go into that because this is outside the purview of this talk. Primarily designed for standard field fundus cameras, and combining ultra-wide field imaging with automated deep learning tools makes it possible to quantify all DR lesions throughout the eye. This is just a picture of the same on the right side with an AI, marked DR changes. Thank you so much.
Thank you, Dr. Saurabh, for your talk. With that, we move on to the panelists for their comments. So, Dr. Lalit Verma, sir, what do you think are the common mistakes that people make while evaluating diabetic retinopathy? Or any other comments that you would like to make, sir?
You see, the importance of this webinar is primarily, I think, for general ophthalmologists.
Yes.
And the two talks, the tenets by Chaitra and science by Saurabh. You see, today, considering the magnitude, 101 million blind, and if treated in time, the thrust is early diagnosis, early treatment, and early referral if you cannot manage. So thrust should be an early referrals or early management. And I believe that if treated in time, most of the blindness can be prevented either by laser, which is the gold standard in PDR, or by injections nowadays. So nobody can afford, or it's all comprehensive ophthalmologists, because everybody wants to shove in the needle. They see something on the OCT and evaluation is lacking. So proper complete evaluation once a patient comes should be there. Like Saurav was emphasizing on wide field. We have been taught that diabetic retinopathy is primarily a posterior pole disease. It may be true, but you can't afford, there are reports that sometimes may start only in the periphery. So wide angle photography also is a must if, wherever centers are there. Then screening by whom, I think that is beyond the scope of this webinar. There are a lot of, publications now that, you can teach technicians, like we are done in our center, also teach technicians to, but the message should be that please evaluate completely, right from, anterior segment to the posterior pole, and also don't forget the periphery. And early diagnosis is the hallmark. Don't jump to keep injections. We see patients, even vitreous hemorrhage, TRDs, or everybody having injections. I would request that everybody should take a color photograph. Comprehensive ophthalmologist, study all those photographs. You can magnify those photographs and study. And do not forget whatever signs. And as far as hemorrhages are concerned, dot and blot hemorrhages are the main thing, and exudates. But superficial hemorrhages and cotton wool spots herald the onset of ischemia. So if you have extensive superficial hemorrhages and cotton wool spots, meaning there was a patient may be heading for a ischemic, conversion to PDR also.
Thank you, sir.
And AI we know is coming in a very big way. Again, that's not beyond the scope. And even, FDA has approved AI cameras also. And a lot of work has been done by Arvind Hospital as well as Shankar Nethralaya with regard to AI.
Dr. Muna, ma'am, would you have your perspectives on this?
Very nice and relevant talks, but I would probably go one step backwards. We've all spoken so much about the diabetologist. We've spoken about imaging, the photographs. But the last few months, I have been so frustrated when I see patients in the OPD who've had their cataracts out, they're diabetics for 20 years. They've, they've gone and got their spectacles from Lenskart and from online things. Nobody has either told the doctor that they are diabetics, nor have they been told by the pharmacist who prescribes the medicine, who gives them the medicines, or the general practitioner that go and get your eyes examined. It's only when the patient comes to us that we can do the investigations. But if the patient doesn't reach you, I think that is the single most important thing I would like to say in this meeting is ask every patient do you have diabetes? They may not consider it important to tell you. And especially when you go in the periphery, you have the CAM patients coming in. Not everybody has all the tests done. I think first and foremost, the diabetic patient has to reach even an ophthalmologist, and then everything else can come. I think for me, that is the biggest frustration right now.
Right. That's a very, very commonplace situation. Every day we see these patients who've not been tended to. So, Dr. Sandeep, sir, Dr. Saxena,
Yeah,
looking forward to your comments or anything in the diagnosis that you think, people miss out, any signs that are, missed out commonly by ophthalmologists.
I'd like to stress what Dr. Bhende said, that we have to have a very close association with the diabetologist, because at least in our institution, from the Department of Medicine, the diabetic patients, as they present to them, are screened by us. So if the diabetologist is in a habit of at least sending the patient over to the ophthalmologist, and at least the baseline screening can be done. So I feel many of the patients who go unnoticed have to be can be found out quite in an early stage. And then, as Dr. Verma also said, that then the things get streamlined, and I feel that is the crux of the management. Management we can do, but finding out or catching the patient at an early stage is the crux of the management.
Yes.
Yeah.
Very rightly pointed out, sir. Thank you so much for your comments. And with that, we'll move on to our third talk, a very interesting talk by a very senior and distinguished VR specialist, Dr. K.S. Kumar. Dr. Kumar is the director of the Kumar Nethralaya in Bangalore. And he will be speaking to us about conditions that mimic diabetic retinopathy and are often confused with diabetic retinopathy. So over to him. Dr. Kumar, sir.
Are my slides visible?
Sir, your screen is visible. The slides are not visible.
You need to open the presentation, please.
Yes, sir, it's visible now. Yeah.
Yes, you are muted actually. You are muted. You have to open. You have to, you are muted, case.
Sir, you're muted.
Yeah, you have to start from beginning now.
Yeah, at the outset, I would like to thank ARC and Dr. Tinku Bali for the opportunity to share and learn from today's presentation. My topic is about imposters or diabetic retinopathy lookalikes. Let me go back to a golden clinical dictum that we all learned during our medical school days. You make a diagnosis of a usual condition and you are usually right. And you make an unusual diagnosis and you are seldom right. So having said that, it becomes imperative that I make a disclaimer here. The object of this presentation is not to promote exotic thinking, but to promote lateral thinking, use our common sense, and not to miss the whole in the part. So we must all look before we leave. And the target audience for today's presentation obviously are the residents, fellows, and budding ophthalmologists, because much of what I'm going to say may be superfluous to the established vitreoretinal surgeon. We are all familiar that most of the retinal conditions, or for that matter, most of the conditions in the eye the diagnosis is based on pattern recognition. So familiarity with the various common fundus features of diabetic retinopathy as well as the optic nerve involvements in diabetes is fundamental. If there is anything that is discordant or is not congruent with the usual familiar features, that should ring a bell. And that is because comorbidities commonly coexist with diabetes mellitus. I call these the fine prints in the fundus picture. Now, when we read these fine prints, it averts needless treatment for diabetic retinopathy when it may not be diabetic retinopathy itself. Specific treatment for the actual condition can be initiated, and many diagnoses that are potentially serious may come into the picture. Now, this is the dichotomy between appearance and reality that we should all be aware of. Going back to the basic fundus features of diabetic retinopathy, which has all been enumerated already. Now, if I tell you that a various permutation and combination of these same findings may mean a different diagnosis, it may almost look paradoxical. So instead of going through it in a usual textbook style manner of the differential diagnosis of non-proliferative, the differential diagnosis of macular edema, and the differential diagnosis of PDR, I thought I will just take you through a series of my own personal experiences. This is really the close cousin of diabetic retinopathy, undiagnosed hypertension in a diabetic. It's almost a partner in crime, if I might use that expression. In patients with diabetes, this is vastly underdiagnosed. It may take various forms like these flame-shaped, superficial, or what has been referred to as the brushstroke hemorrhages in the fundus, or the set of photos in the bottom half where you see only the veins, the arterioles are hardly visible due to a generalized spasm. It may also take the form of multiple cotton wool spots in these, as in these eyes. And when you treat the hypertension, you see the fundus picture changing in the set of photographs below, unveiling the underlying PDR, and then that can be appropriately treated. So if you have mirror image patterns like this in the two eyes, it's more likely to be a hypertensive related retinopathy, because diabetic retinopathy may not always be so symmetrical as you see in the set of photographs here related to hypertensive retinopathy. This is a young patient who was an insulin-dependent diabetic. She presented with severe loss of vision of abrupt onset for 4 days. And when we see these pictures, you see all the manifestations of acute hypertensive changes in the fundus. Hypertensive optic neuropathy. She has these Elschnick spots, which are choroidal infarcts, yellowish punched out lesions. And she also has hypertensive retinopathy. So these things we should not be missing in patients who are diabetic. The other point which I wanted to mention about hypertensive retinopathy is when the hard exudates are limited to one side of the horizontal raphe, either above or below, then it's more likely to be related to a tributary vein occlusion and hypertension, and the collaterals on the FFA will be lending further credence to that. Another condition which we should not be missing, this patient was referred to me as a PDR. He did have new vessels on the optic disc and glaucomatous optic atrophy in the other eye, but you see these equatorial hemorrhages in both in the right eye, and fundus fluorescein angiography shows typical slow flow retinopathy with the visible edge of the dye, leading edge of the dye visible, and of course neovascularization of the disc. This patient did undergo PRP, but the diagnosis was completely different on evaluation. He had an ocular ischemic syndrome. More pictures of the same equatorial hemorrhages as you can see here in the right eye, but the left eye is being perfectly normal, a diabetic. And fundus fluorescein angiography is critical for making a diagnosis of ocular ischemic syndrome, which we should not be missing. Some of the other lookalikes, NVD has been spoken about with the rare situation of diabetic papillopathy, where you have these radial dilated epipapillary vessels, each of them ending in a microaneurysm like bulbous ending, almost like fiber optic cables on the optic disc. They don't leak fluorescein. Non-arthritic AION, where you have sectorial pallor with luxury perfusion in the remaining part of the disc. This pattern may, of course, not be seen in all patients. So any form of disc edema should not be mistaken for neovascularization of the disc. And of course, we have Bergmester's papilla, which is a remnant of the residual posterior primary vitreous. Disc collaterals should not be mistaken for new vessels, which are usually seen post-CRVO resolution or in patients with glaucoma. This is an interesting patient who was referred to me as TRD. But when I did the OCT, he had normal vision in the left eye, and to me it looked like just a very big Bergmester's papilla with fibrous proliferation along the arcades. There was no other visible sign in the fundus that necessitated any treatment. Now, pale-centered hemorrhages in a diabetic may be seen. Sparse pale-centered hemorrhages may be seen, but when there is a preponderance of these pale-centered hemorrhages in the fundus, it must generate a lively suspicion to look out for hematologic disorders. In this case, it turned out to be CML. This was yet another patient, a middle-aged adult, who presented with these pale-centered, superficial, and deep hemorrhages, and on investigation had a hemoglobin of 5, and on further investigation, he had rectal CA that was treated, and the anemia once treated, you can see this fundus picture completely normalizing. Another interesting patient, a lady who was in her 60s, presented with these kind of hemorrhages in the right and left eye. And if you observe closely, the branch retinal vein occlusion in the lower temporal quadrant of the right eye also has multiple pale-centered rod spots. And these are the OCT pictures, which not only showed macular edema, but also fluid in the peripapillary location and multiple loculated fluid nasal to the disc as well, temporal to the disc as well. So these kind of subretinal fluid accumulation and pale-centered hemorrhages, we investigated her thoroughly, and unfortunately for the patient, she had this spike, a paraprotein spike in the B2, in the beta globulin 2, and it turned out to be multiple myeloma. So this patient was referred for intravitreal injections, but we should not be, as Lalit was mentioning, we should not be hurrying in to inject, because this patient had multiple myeloma, which was never diagnosed. Yet another patient who had these large preretinal hemorrhages gave a history of gum bleeding that was thought to be related to gingival disease in diabetes, but the patient had thrombocytopenia that was appropriately managed. Yet another patient who had a head injury while when he was involved with a motor vehicle accident, and these were some petal-shaped hemorrhages in the macula and preretinal hemorrhages. He had headache and was treated for Terson syndrome. This patient was referred for panretinal photocoagulation, but the hemorrhages resolved once his general condition improved. Of course, diabetes can also present with these preretinal hemorrhages, but the other eye picture will give us important clues to the diagnosis. A diabetic retinopathy patient who had developed nephropathy and had to be dialyzed, and in the interim developed these classical features of CMV retinitis in the fundus, an add-on to the diabetic retinopathy. The other conditions that are often misdiagnosed as diabetic retinopathy is various forms of central retinal vein occlusions. The other eye, as I said, gives important clues for the diagnosis. Renal retinopathy, there's nothing distinctive about it, but when you see a preponderance of hard exudates, not just at the macula, but all over the fundus, and you see these large blot hemorrhages and occluded arterioles, this must prompt us to investigate for nephropathy in these patients. The other important condition where the diagnosis is missed is the presence of macroaneurysms in patients with diabetes. This is a patient who was referred to us for intravitreal injection of gas and in the left eye, and for intravitreal injection of anti-VEGFs for macular edema in the right eye. But the patient was hypertensive, which was not known hitherto. And then once that was addressed, this is the ultimate picture. So everything resolved, and the patient got back nearly normal vision. So these are some of the things that we should not be missing, and we should take on the role of a Dr. Doolittle in these patients. Controlling the hypertension is of utmost importance. So beware of multiple pale-centered or splinter hemorrhages, or large blotchy multi-layer hemorrhages, or significant vitreous hemorrhage in association with PVD. It may be related to something else in patients with diabetes, and equatorial blot hemorrhages, as we alluded to already. Then when we have these kind of dense hard exudates in the macula, almost looking like Best's disease, this is of course diabetic related, but then this patient had abnormal cholesterol and triglycerides. And once that was addressed, this was the fundus picture. The set of fundus photographs in the bottom show you that a large amount of the hard exudates have disappeared. Same with this set of photographs. Diabetic maculopathy for sure, but then the dyslipidemia, which was significantly there in this patient, was addressed, and you could see that a major part of the hard exudates have resolved on their own. These are some of the other things that we should not be mistaking for diabetic macular edema. This patient had undergone some nondescript laser beyond the arcade with a diagnosis of diabetic macular edema. This patient did not have diabetic macular edema, but instead had drusen and dry ARMD in both eyes. The set of photographs below, when you have these hemorrhages around the fovea in a petaloid pattern, that is not diabetic macular edema. This patient, once you subject them to fluorescein angiography, the patient had succinate in the right eye, but once you subject them to fluorescein angiography and OCT, this patient had PCV that responded very well to intravitreal anti-VEGFs. But of course, the patient had a subsequent stormy course, which is a different matter. The other important point which I wanted to emphasize is apart from the petal-shaped hemorrhages around the fovea, if you see perifoveal graying like this in association with hard exudates, that again suggests that the patient may have something like a CNV, as in this patient, that responded well to anti-VEGFs. Parafoveal telangiectasias many times look like, to the uninitiated, look like diabetic macular edema, but then these patients usually don't have other signs, but some people may have other signs of diabetic retinopathy. Contrary to macular edema on OCT, in these patients, we see retinal thinning and many times intraretinal cavitary changes. We come to the other important issue of managing vitreous hemorrhage in patients with diabetes. Many times these patients are given intravitreal anti-VEGFs or operated upon as also, but you have to look at the other eye. This was a myopic patient, as you can see from the fundus photographs. And as we followed these patients up closely, as the hemorrhage resolved, there was no evidence of any retinal tear or a branch retinal vein occlusion or trauma. And the patient resolved very well merely by waiting. So we should arrive at the proper diagnosis and not assume that all vitreous hemorrhages in diabetics are related to PDR. Another interesting patient who he had multiple, almost 16 intravitreal injections of anti-VEGFs for diabetic macular edema with hard exudates. It was not resolving. Although there was no evidence of a leaking macroaneurysm on the FFA, we thought there was something here, a dark red lesion with spidery extensions around it. We did go ahead and treat that, and this is the ultimate picture. The hard exudates resolved. The patient's vision didn't improve significantly, but then the fundus showed significant improvement. Another patient who presented with these hard exudates, a young male patient who presented with these hard exudates in the left eye macula, and on fluorescein angiography, you see these multiple miliary aneurysms. We were not inclined to believe that these are secondary macro aneurysms related to a vein occlusion because there was no evidence of any collaterals in this patient, and with laser treatment, we were able to get rid of a significant amount of hard exudates. So this is not diabetic macular edema. That was the OCT picture related to the patient. Many times, dense hard exudates at the macula may be a red herring. We may be focusing on the macula, but blissfully unaware of what is happening in the rest of the fundus. This patient had extensive capillary non-perfusion related to a vein occlusion and NVD as well. And this, when we treated this with laser alone, and this is the fundus picture and the corresponding OCT of this patient. Some of the other things are a rarity. This is a patient who was had macular hard exudates, a diabetic macular hard exudates non-resolving, and had perivascular sheathing that was thought to be related to occlusive disease. But on fluorescein angiography, you see these nodular hyperfluorescent lesions along the veins. There's evidence of vasculitis in this patient. The patient had SLE, and on appropriate immunosuppression and systemic therapy, the ocular signs significantly got better. And these are the OCT pictures of the same patient. So retinal findings of hemorrhage and hard exudates in a diabetic may not always be diabetic retinopathy. If it is unilateral, asymmetric, or very symmetrical, beware that it may be something else. Life-threatening signs may coexist with diabetic retinopathy, and the onus of diagnosis rests with the ophthalmologist. This is another set of photographs where macular hard exudates in a diabetic, the fluid was not resolving on the OCT, but a closer look showed that the patient also had an optic disc pit, and we did laser to the margins, the fluid disappeared. Some other patients with macular hard exudates may be related to an idiopathic CNVM, as in this patient, that resolved well with anti-VEGF agents. I will conclude with another 2-3 photographs. This is a diabetic patient who presented with these dilated veins in both the fundi, but no evidence of diabetic retinopathy. And on routine investigations with a complete blood count, he had hemoglobin of almost 19. And this was finally deduced to be related to a secondary polycythemia due to his chronic smoking habit. Again, for those who are less experienced, these kind of backwardly directed squiggly veins in the retina are a congenital venous tortuosity and not venous dilatation related to diabetes. And when the same dilated vessels have a pinkish hue, then this is lipemia retinalis. So to avoid pitfalls, we should be adopting the right attitude and practice, attend CMEs such as this one. Proper examination techniques are extremely important. I remember one of my professors saying that a misleading sign or symptom is misleading only to one who is willing to be misled. So it's not what you look at, but what you see that matters, what you see or observe that matters. So it is important for us to be cognizant of these other findings. All of these are the same findings that we see in diabetic retinopathy, but they appear in different sequences and different permutations and combinations. And I have tried to highlight some of these. So till artificial intelligence takes over and tells us that this is diabetic retinopathy, or this is hypertensive, or this is multiple myeloma related retinopathy, I think we should be using our innate intelligence and apply our mind and common sense. Thank you very much for the opportunity.
Thank you, Dr. Kumar, sir, for that very interesting collection of cases. So you very nicely highlighted all the pitfalls in the diagnosis of diabetic retinopathy. So they say the mind sees only what it knows, and you've shown us and such a a vast array of pictures. So I think we are all very well, everyone's very well informed about how not to misdiagnose diabetic retinopathy. So with that, I move on to the chairpersons. Dr. Lalit Verma, sir, what would your comments be on this?
I think kudos to Kumar for highlighting so many things. Only 2 or 3 comments. One is all retinopathy in diabetics need not be diabetic retinopathy. You see, diabetics are not immune from developing ARMD, PCV, or other diseases. A second point is that all maculopathy also is not same as diabetic maculopathy. He showed very wonderful examples of PCV or macroaneurysm. So people, these things happen if you do not pay attention to history taking, complete clinical examination, and also lab examinations. He showed polycythemia, hemoglobin 19. So, and overlooking these things happen primarily if you're in a hurry. If you're in a hurry to, inject, these things are bound to happen. If you see hemorrhage in the macula or, some kind of retinopathy, people are in a hurry to inject. So, nutshell again is same. Complete evaluation, clinically, history taking, laboratory are a must before you jump into treat.
Sure, sir. Mona ma'am, what would be your comments?
Kumar, as usual, excellent presentation and very nice practical tips. I would just like to emphasize that one more point is bilateral CRVO in a diabetic. Sometimes they say very severe NPDR, is it CRVO? Very often that's indicator of chronic myeloid leukemia. And also bilateral macular edema, you showed that nice patient with multiple myeloma. It's fairly common when you have bilateral neurosensory detachment. Just look at their blood counts. They may tell you blood sugar is okay, but if you look at their blood counts, so just get a peripheral smear, you may pick up something. And most MACTEL patients have diabetes, but may not have diabetic retinopathy. Diabetic retinopathy in MACTEL is not that common. So that's another thing. And I think there's already a talk on don't be in a hurry to inject. So I guess he will tell us more about that. But excellent, Kumar. Very nice.
Thank you.
Examples.
Dr. Saxena, would you have any perspectives on this? Dr.
Yeah, I think very nice collection of cases which Dr. Kumar has presented. And I feel that when a patient goes to a retina specialist and he says that he is diabetic, sometimes we are swayed that now we are going to find some kind of findings in the retina related to diabetes. So I think one has to keep an open mind and try to look sometimes beyond diabetic retinopathy also, so that we are not swayed with those kind of things which might be happening, and we don't send the patient with a wrong referral also. Thank you.
Thank you, sir. So after that very interesting and illustrative talk, we move on to our next talk, which will be by Dr. Anisha Seth Gupta. Dr. Anisha is the director of the GNH Excel Hospital at New Delhi. She's also in charge of the ROP services at the Max Super Specialty and Fortis Hospitals, Shalimar Bagh, Delhi. So Dr. Anisha would be telling us all about OCT in diabetic macular edema, what all information it can give us and how it can help us in our management. Dr. Anisha, over to you.
Thank you, Dr. Tinku, for giving me this opportunity. Thank you, AIOS. It's an honor to be a part of such an esteemed panel of ophthalmologists. Are my slides visible?
They're visible. Please
all right. So my topic is about OCT in DME, what all it is going to tell us. So with the newer OCTs, we get such a detailed view of the layers of the retina that it is actually wonderful, and we can come to know that it is just not the edema that is there, but a lot of other things which I'll share you today in my presentation. How to read an OCT, first of all. You see the vitreoretinal interface, foveal contour, macular thickness, inner retina structure, outer retina structure, RP, CC complex, and choroidal thickness. But in a case of DME, we are basically bothered about the top 5 points. First and foremost, that when we order an OCT for a patient of DME, suspected DME, we ask the patient to get an OCT done, and most of the general ophthalmologists or whosoever is getting the OCT done gets a printout like this, and this is what we see, the thickness scan. Now, this is important, but this is not the only thing. Here you see the thickness scan, it's absolutely normal, green, we are good. But then just this is not enough. We have to look at the structural map of the OCT as well. It is important not just to see the center, but all the cuts need to be seen, because you'll be surprised to see what you will find even with the normal thickness scan. Also, the retinal thickness is neither prognostic nor predictive of the final outcome. Other factors, pattern of DME, extent of retinal involvement, which layer is involved more, what is the status of the inner and the outer retina, are more important. So the structure is much more important than the actual thickness. This is just a representative picture to show how the thickness map can actually make us confused. This is patient A. You see these yellow patches in the retinal thickness map. You feel that it is not normal, but this is actually an absolutely normal macula. Similarly, patient B, you see these pink areas which depict that there is an increased macular thickness, but then this is an absolutely normal macula. There is no pathology in it. So just going by the macular thickness map is not the right way to go. Variations are present. Do not go solely by the macular thickness map and compare with the other eye if the other eye is normal. So if once you get into the macular retinal thickness, you see if it is an increased macular thickness, and once you know that it's an increased macular thickness, you see what kind of edema there is. There's the spongy edema. Is it cystoid? Is it a neurosensory detachment, tractional, or all of them? And if it is decreased macular thickness, this is most likely there's an ischemic event that has occurred causing a foveal thinning. But what is important here is that the presence of macular edema does not rule out ischemic maculopathy. So even if there is a lot of macular edema, that doesn't mean that the ischemia is not there. And that is where comes in the role of the other biomarkers that I'll be mentioning now. This is a very standard classification by Otani in 1999, who initially classified on the basis of OCT, the type of edema. We have the spongy edema, cystoid edema, neurosensory detachment, and tractional edema. So coming back to the vitreoretinal interface, the tractional macular edema is the one that we first need to rule out, because that is not what is going to respond to a pharmacological agent, and we have to refer the patient to a vitreoretinal surgeon. So this is a patient where you see a thick ERM on the surface of the retina. There is increased retinal thickness, but if you see the fovea is reasonably all right. It's not very thick. The patient's vision was 6/9 at this point. The patient had no symptoms, and I did not treat the patient with anything. We're just following up the patient. This is another case. You see an ERM building up on the inner retinal folds. You see there is a membrane developing, and along with that, there is macular edema. There is increased thickness. But this edema is not because of the traction. And here, pharmacological intervention will help. Anti-VEGFs or steroid, whatever you want to give, would help the patient improve vision, although there is an ERM. What you need to be worried about is these kind of macular edemas, where there is a very taut membrane pulling up the fovea, pulling up the macula. These patients will not respond at all to any pharmacological intervention and do need vitrectomy. So thickness plus traction, then the traction should be explaining that increased thickness that indicates a tractional macular edema, and that patient requires a surgery. Spongy macular edema is probably the most common that we find. This is an increased retinal thickness diffusely. The edema is seen. You see these black areas in the outer plexiform layer, small areas of blackish fluid pockets. And this indicates generally a good prognosis. They respond very well to all forms of treatment, even focal laser if it is done, if it's an extra foveal or a macular leak. The focal laser also works very well on this kind of an edema. Cystoid macular edema is a very important biomarker in predicting the functional outcome of DME. Why? Because there are different sizes. The classification is of different sizes of the cysts. But if the cysts are very large, more than 200 micron in size, they are indicative of either a long duration of DME, degenerative changes, or ischemic changes. And hence, whenever we have very large cystoid spaces, we have to keep in mind that the patient has a poorer visual prognosis despite treatment. It doesn't, that doesn't mean that we don't have to treat the patient. It is only for the purpose of prognostication that yes, it might be a long-standing case of DME and the vision gain may not be that great. Presence of a neurosensory detachment is, it is generally accompanied by either cystoid or spongy edema. Independent neurosensory detachment is generally not seen in cases of DME. It is seen in 15 to 30% of cases, and again is an important OCT biomarker of inflammation. So when you see this, it is said that probably they will respond more to intravitreal steroids as compared to anti-VEGFs, although practically they respond well to, again, all kinds of treatments. Presence of neurosensory detachment is also an indicator of a defective kidney function. So it's always better to get the kidney checked at that point. Coming to the inner retina, the drill or the disorganization of the retinal inner layer is a very important factor. This, we see the ganglion cell layer, inner plexiform layer, inner nuclear layer, and outer plexiform layer. So on OCT, these layers should be beautifully well-defined seen, but when there is a drill, we will not be able to distinguish between these 4 layers. So as in here, you see drill is measured for the central 1 millimeter of the fovea. If more than 50% drill is seen, this disorganization of the retina is seen, inner retina is seen, we label it as drill, and it is a poor prognosis, visual prognosis indicator. So you see the scan A and scan B, they are the same scans, and you can very well see the layers moving in from the nasal, from the left side to the right side as depicted in the B scan with the red dotted line. Coming to scan C and D, again the same OCT. You see from one in the middle there is a cystoid edema, but when you follow these inner retinal layers, you can see them on either sides of the CME, but at the place of the cystoid spaces, you cannot differentiate the layers. So this patient has a drill. This is a very important biomarker, and it should be seen whenever you are about to treat a patient of DME. Drill may or may not be associated with a central involving DME. You see in the first case in the case A, the central part you cannot see any well-defined layers, but there is no edema. Despite no edema in the center, this patient is bound to have a poorer vision as compared to patient B, where there's a large cystoid space in the center, but above the cystoid space, you can still see those layers, inner retinal layers moving in, and hence this patient will respond well to the treatment and the vision gain would be better. Another important biomarker in OCT is this hyperreflective focus, these small white dots that are very commonly seen. Now, these can be easily confused with hard exudates, but these are not clinically seen, while hard exudates are clinically seen. So how are they different from hard exudates? They represent subclinical lipoproteins that have extravasated because of the breakdown of the blood-retinal barrier. They are present primarily in the inner retinal layers, while the hard exudates are present mostly in the outer retinal layers. The size is small, less than 30 microns, and there is total absence of backshadowing. In hard exudates, you will always see some backshadowing on the OCT. These are again a very important OCT marker of inflammation, and they are. Many studies have proven that when you find them in the OCT scan, again, if the patient is especially pseudophakic, go for a steroid treatment first before, as compared to an anti-VEGF, they respond much better, and after the treatment, they disappear also. Hard exudates, as has already been covered, it's a clinical diagnosis. You can see those cholesterol lipid deposits, and they are seen in the outer layer. There is a backshadowing on OCT, so that is how you make out these are hard exudates. And they disappear with treatment, but they take a very long time to disappear. And again, they are known to respond better to steroid injections. But the problem is this kind of a picture where you have these hard exudate right subfoveally. So these patients do very poorly vision-wise because there's nothing that we can do. Even if the hard exudates disappear with time, the scarring has already occurred, the damage has already occurred. Coming to the outer retina, as in all the retinal cases, we have to see this part. The outer retina, we have to see the photoreceptor, the ISOS junction. And here, if there is a DME and you can make out, as in this picture, you can make out on either sides of the cystoid space, you can see the ISOS junction going, but in the middle, where there's a cystoid space, you cannot see any line. So the ISOS junction is damaged here. Now this patient, again, you have to treat, but despite treatment, after the resolution of edema, something like this will happen, and the central scarring will still there, the ISOS junction will be disrupted, and the vision gain will be poorer. This is a representative case, a patient who came to us in June 23 with PDR, laser PDR with CME, given anti-VEGF treatment, responded also, improved, and then lost to follow up, then came back after 18 months with a very thick ERM. The patient was getting injected with aflibercept elsewhere and was not responding, so came back to me. But at this point, you see the ERM is so taut that the anti-VEGF is not working. Nothing will work except the surgical part. So the same patient over time can move from a simple macular edema to a tractional macular edema as well. So take home points, OCT macula is the most important investigation for the management of DME. Do not go solely by the thickness map, do see the scans. If there is an increased retinal thickness, look at the type of macular edema. If fractional edema, then poor response to pharmacological treatment is there and surgery is the way to go. Look for biomarkers of inflammation. If there is a neurosensory detachment or a hyperreflective spots, consider giving intravitreal steroids as primary treatment, especially if the patient is already pseudophakic. And look for prognosticating markers like drill, ISOS junction health, because prognosticating the patient is important before starting the treatment. Thank you for your time and attention.
Thank you, Dr. Anisha, for so beautifully highlighting all the important points in how a general ophthalmologist should look at the OCT. You also highlighted that it's very important to look at the scans and not just the thickness maps, which a lot of people do. So with that, I move on to the chairpersons. Dr. Muna, ma'am, would you have anything to add to that? Or
Very nice overview, Anisha. Very often the patient comes to you with an OCT image. So if you are in the clinic doing it yourself, then it's easy to go through the scans. But getting a thickness map is a reasonably good guide, because sometimes you may have that's edema off center, like Lalitsa's background. It may not show much on the OCT, but the thickness map will tell you which areas have the thickening, and that's where you need to look. So it's good to have it as a guide. Do the cube scan as a screening, and then go for your radial scan, so you'll have much better information and you can plan your treatment much better. But excellent talk, very well done.
Thank you so much, ma'am.
thank you. Dr. Lalitsa?
I think excellent talk. She has covered OCT is the backbone of assessment of diabetes, and she has very nicely told, but both from diagnostic as well as prognostic also. And she has hinted about inflammatory markers, because from the prognosis point of view, 2-3 things have to look for. One is drill and the integrity of the outer 3 layers, ISOS and ELM and the drill part. And very nicely you have told about, because today only in clinic somebody was asking about hyperrefractive foci and hard exudates, and very nicely I think people who are listening. So people who have cystoid or NSD or inflammatory markers, so our tentacles are high in the form that we may shift to steroids after, at a very low threshold. So we should not keep persisting with if the response to anti-VEGF is not coming. OCT is quite an educative tool also. You see, I'm very fond of explaining. It's an educative tool, like tell the patient this is how a normal OCT looks. These are the layers. So patient becomes very responsive to your counseling and advice, and show him and the family of the need for a regular follow-up. So it's very important, in the beginning when Tinku started this, that it's very important that all the family members should be involved in the management. It's not that, because once we talk of OCT or diabetes or other things, it's the family. It's a diabetes, a familial disease. It's not familial means not running the family, because the whole family has to cooperate with the patient. We just can't tell patient by aap ye nahi karo, but the whole family has to be involved. Therefore, I tend to educate these patients, the husband, wife, whosoever comes along, that this is what is happening in the retina. Retina is the seat of vision, and if you don't, you may lose vision permanently. So use your color picture, OCT, to teach the patient, apart from whatever you said, diagnosis, management, to, educate the patient, relatives, everybody.
Thank you, sir. So does drill improve with treatment, or is it like,
I don't think so. I don't think so, because it's, there's no way to establish the age of the drill since when it is there. By and large, drill means the entire retina is, the neural elements are disorganized, and it generally does not.
Dr. Sandeep Saxena, sir?
I think very nice talk. and I'd like to supplement this with a couple of our researches done about 12 years back or so. So we had shown that the CST in OCT is directly related or directly correlates with the serum VEGF levels. So instead of now, I think that having a categorical type of NPDR, PDR, we have to have a sort of a continuous variable where with the help of OCT, we can monitor and we can know whether the VEGF levels in the body are going up or down, because that will have an effect on the eye as well as on the glomerulus in the kidney. So now, if you're following a patient and his CST is continuously going up, that means that the VEGF level is increasing. So within that stage of NPDR or PDR, the things are going bad. So that is an indirect sort of an indication. The second thing which I'd like to highlight was that around 12 years back, we discovered the mechanism of ellipsoid zone disruption in cases of diabetic retinopathy. And we showed that the ELM serves as a barrier. So once the ELM goes off or starts to disrupt, the ellipsoid zone will also disrupt. And then after a decade or so, a time frame or something, we showed that with the anti-VEGF therapy, the ELM starts to come back first, and then the EZ restoration starts. So if the patient asks that how good or bad he's doing, so on successive OCTs, if the ELM is restoring back, so that gives us a prognostic indication that the patient is likely to do well with his continuous anti-VEGF therapies. Thank you.
Dr. Tinku, you're mute. Please unmute.
So with that, we move on to our next talk. And this is about anti-VEGF. This is about injections by Dr. Ruchir Tiwari. Dr. Ruchir is a very young, dynamic vitreoretina specialist. He's a consultant at the Tiwari Eye Center in Ghaziabad and Noida. And he'll be speaking to us on the management of DME, when and what to inject and when not to inject. So this is a talk that, everyone wants to know when to inject, when not to inject. So Dr. Ruchir, I hope you'll be solving a lot of queries with your talk today. Thank you.
Good evening, ma'am, and to the panel, and thank you, AIOS, for giving me this opportunity. At the outset only, I would like to say that most of the things that I was supposed to say have already been covered in other talks. So it's going to sound a little repetitive, and I've tried to make this a case-based discussion. So I'll be talking about injections, intravitreal injections, what, when, and when not. So first we talk about what. So what are we talking about? We are talking about modalities for treating diabetic macular edema. Now, initially to begin with, we had lasers, then we had intravitreal steroids, and then finally we had intravitreal anti-VEGF agents. So anti-VEGF agents for now form the backbone of our treatment modalities. They are the go-to drugs for us. With time, now we have different generations of anti-VEGF, if we can classify them like that. Bevacizumab, ranibizumab, and aflibercept are the older generation of drugs which we have been using for a very long time. We have a lot of data based on their safety and efficacy. And then again, we have the newer generation of anti-VEGF, brolucizumab and faricimab, which are newer drugs. They are supposed to be longer lasting, more durable, more efficacious, but then definitely they do have their down points as well. And cost also factors in. We also have steroids, as Anisha ma'am has already shown us a few cases of intravitreal steroid use. Triamcinolone is the original intravitreal drug that was used for macular edema. With suprachoroidal now, it would become a different situation for us because the complications rate goes down, but unfortunately we don't have data. And then we also have the DEX implant. We do have closonolone implant, but I don't think that is available to us still. So steroids are not generally used as first line because of their potential complications. Cataract is a given for all patients of intravitreal steroid use, and intraocular pressure rise and intractable glaucoma that is seen in certain cases. So steroids, of course, you should never demonize any drug, because in cases where anti-VEGFs are not working, steroids are still our go-to medications. So when do we treat diabetic macular edema? So this is a chart that I got from ASRS, which actually describes DME and what DME is to be treated and what DME is not to be treated. So we can again differentiate between the two types of DME, center involving and non-center involving DME. Any DME that is non-center involving may be closely observed and not treated at all, because vision is not affected per se, and systemic control, metabolic control should lead to resolution. Now, when we're talking about center involved DME, again, we'll have two categories of patients, one with visual acuity preservation and one with visual acuity loss. So most of the patients that come to our clinic are actually center involving DME associated with visual acuity loss, and these are the patients that we usually treat with intravitreal agents. So anti-VEGF is still our first choice for managing DME. Bevacizumab is still the go-to drug for most of the ophthalmologists, and ranibizumab followed by aflibercept. So the first case that I'm going to show is a 60 years old male, BCVA 6/12, HbA1c is 7.8. So not very well controlled, but not really bad. So this is a typical picture of a treatment naive DME that we get in our clinics. We see large cystic spaces, some hyperreflective material inside the cystic spaces. And this is a classic case of center involving DME with visual acuity loss. We treat this patient with anti-VEGF, and with multiple anti-VEGF injections, patient's vision goes back to 6/6 and more or less the foveal contour becomes normal. The second patient is 65-year-old male, bilateral DME, very poor systemic control, BCVA of 6/36. So this is the right eye of the patient. As we can see, there is a thin ERM, large cystic spaces. As Dr. Anisha has already told us, there are hyperreflective foci as well. So at this point in time, because the ERM is not much, it is still amenable to intravitreal injections. So this is center involving DME with visual acuity loss and ERM. But when we treat with intravitreal anti-VEGFs, the vision improves and the macular thickness also goes down. However, the key point was to highlight the poor systemic control of the patient. What happens when you keep on treating such patients over a period of time? So this is after 3 years of multiple anti-VEGFs, multiple steroid implant, and a vitrectomy for the ERM, followed by anti-VEGFs and steroid implant. This is the OCT picture. So now you can see that there is a lot of drill, large cystic spaces. The visual acuity of the patient is 660, and there is no further anatomic improvement with any injections or any other treatment per se. So key again is to make the patients realize that diabetes is a systemic disease. We can only treat the manifestations in the eye, but we cannot make the disease go away. Now, when does focal laser come to our rescue? This is a 65-year-old female, diabetic for 20 years. HbA1c is more or less controlled, 6.8. BCVA 618. And she was not responding very well to anti-VEGF agents. So if you look at the OCT picture, it looks like a classic cystic DME, but the patient was not responding to anti-VEGF agents. When I do an angiogram, what I get to find is 3 very large microaneurysms which are profusely leaking. So once I add laser to these leaking microaneurysms and I change the anti-VEGF agent, the macular structure goes back to normal and vision goes back to 6/6. So not all patients will respond to intravitreal agents only, and focal laser still has a very big role to play. The next patient is a 58-year-old female, diagnosed as DME. She had incidentally underwent cataract surgery 4 months back, after which there was no vision gain. Vision was 6/36 still. She was given anti-VEGF agents, but she did not respond well. So if you look at the fundus picture, we can see few microaneurysms and a cystic macular edema. There are few hard exudates as well. What happens when we do the OCT? We see a large neurosensory detachment, intraretinal cystic spaces. What happens on the angiogram? As we move along the angiogram, we see that this patient is actually suffering from a major component of post-cataract CME and a very little component of DME, because the microaneurysms are actually not leaking much. So this patient was given a DIX implant, and this is what we see after a month. The edema has gone down, neurosensory detachment has gone down, cystic spaces have all but gone away. So we need to make our diagnosis right in all cases before we start the treatment. So when do we give steroids for DME? As I mentioned earlier, recalcitrant disease not responding to anti-VEGF, we have to shift to steroids. Second is patients undergoing cataract surgery where we want the disease not to come back early. Pseudophakic patients again was a go-to for me until the newer anti-VEGF agents came up, and now the patients are responding very well to those. So pseudophakic patients may not be the first line treatment, may be steroid. And the last but most important thing would be florid PDR and DME. Now, this is one set of patients who do not respond very well to anti-VEGF agents and may lead to a crunch phenomena. So if we need to manage their DME and do a slow PRP, steroids really help. Apart from that, the hyperreflective foci and the bad prognostic factors, as Dr. Anisha said, are indications for steroids. Now, we do have newer anti-VEGF agents now, which respond really well. This is a 58-year-old female, bilateral DME, poorly metabolic controlled. These are the OCT images from the initial visit. We see both eyes have neurosensory detachment. Left eye shows a lot of hard exudate subfoveal region. She was asked to control her HbA1c levels and come back. Unfortunately, patient went to a different city during that time. She came back after 6 months with history of 3 ranibizumab and 1 aflibercept in each eye. HbA1c had gone down to 8. These are the OCT pictures from that time. Patient did not seem to have responded well. Now, again, as we have discussed earlier, hyperreflective foci and neurosensory detachment, poor systemic control is an indication for steroid implant. So the patient was injected with DEX implant in both her eyes. 2 months later, the OCT picture seems better, but the fluid has not gone away. Paradoxically, at 3 months before the drug disappears, the macular edema again came back. So this was a time to shift the patient to another drug. So I shifted the patient to brolucizumab in both her eyes, which is a newer anti-VEGF agent. At 1 month, nothing much seemed to have happened. However, at 3 months, when we look at the fundus, the fluid is gone. So all the anti-VEGF agents that we have, anti-VEGF agents and intravitreal agents that we have are actually just a tool in an armamentarium. We need to mix and match to find what works for our particular patient. The patient responded well till 6 months. Now, the most important thing is when not to inject. So again, 40-year-old male, right eye blurring of vision, irregular metabolic control, BCV of 6 parts. The fundus picture shows few hard exudates and few microaneurysms. The OCT shows general thickening of the fovea and a sectoral edema, 378 just below the fovea. So this is a classic patient where if you go through all the OCT scans, you may find some cystic spaces somewhere, but this patient does not require any intravitreal therapy. We have data from protocol V now telling us that patients with 6/9 or better, even with center-involved DME, may be very easily observed and metabolic control will serve the purpose. Injections are only required when the vision drops down beyond a certain threshold. So good metabolic control, lifestyle modifications, maybe topical nebafenac, and 3 monthly review for this patient should solve the diabetic macular edema in this particular case. The next patient is a 65-year-old male. He's a one-eyed patient, left eye BCVA was 660. This is the fundus picture. So if we look closely, the patient is an unlasered PDR. Macula is showing hard exudates. But the most important thing to note is the fibrovascular ring surrounding the disc. Now, when I do the OCT, there is no tractional component seen per se. There is neurosensory detachment. But above the disc, we can see fibrovascular proliferation, which actually corresponds with the fibrovascular ring that is visible on the fundus picture. So this patient was advised to get a steroid implant along with slow PRP. However, the patient wanted faster results. He went to some other place, comes back after a month with the history of an anti-VEGF agent. Now look what has happened. The nasal side seems to have detached. The macular edema has increased, and now this patient has landed for surgery, and no amount of intravitreal agents are going to help this patient. So this patient undergoes surgery, and finally the macula becomes all right. The vision comes back to a certain extent. The next patient, BCVA 2/60. So these cases, Dr. Kumar also showed us these cases where we see a lot of hard exudates. When we do the OCT, we see a large cystic space and we are very tempted to treat the patient, but there is loss of, there is a lot of ISOS disruption and there is a large area of drill. So once you see that the vision is not actually corroborating with the OCT, we should get an angiogram done, and we should look at the OCT in a more characteristic manner to find any other findings. So when I look at the angiogram now, there is a large disorganized foveal avascular zone, which is signifying macular ischemia. So no matter how much you treat this patient with anti-VEGF agents, vision is not going to improve. And finally, at the end of the day, it is the vision that we are going after. So this patient does not require any further intravitreal treatment. Now, not all diabetics have DME and not all cysts are fluid. Now, these are two very particular cases that I got once in my clinic. The first patient is a VMT, but if we just talk about the characteristic features, then the patient has cystic spaces and neurosensory detachment. This patient was advised anti-VEGF injections elsewhere. This patient would not have responded at all. Patient underwent a surgery, and after certain time, she was all right. Next, as Dr. Kumar has also showed us, a lot of patients come to us with diabetic retinopathy or with diabetes with a picture like this. So female patient with a picture like this, you look at the macula, you see cystic spaces. Unfortunately, these are not diabetic cystic spaces. When we look at the fundus, we realize that the patient is type 2 MACTEL. This patient will not respond to anti-VEGF agents. It's a degenerative disease and they only need close follow-up. So intravitreal agents, again, steroids and all types of anti-VEGF agents are the backbone for managing DME. Still, laser has a role to play, specifically focal laser in cases which are not responding, and angiogram definitely helps. And at the end of it, we have to treat the patient and not the OCT. Thank you for your patience.
Thank you, Dr. Ruchir, for that excellent exposition, and you backed it up with, real life case situations. So it was very interesting. Thank you so much. So I'll just ask our panelist, Dr. Saxena, sir, what would be your comments on the, on the anti-VEGF injections? Anything that you would like, any pearl that you'd like to share, any perspective? Dr. Lalit Verma.
Okay, yes. Now, I think it was a very nice presentation, and we have to be careful that which anti-VEGF agent we are choosing when we are sure now that the treatment has to be done. And we also have to look at the pocket of the patient, that what he can afford and what kind of benefit a patient can get. So all these things have to be taken into consideration in our kind of scenario. The best anti-VEGF agent will always remain the best, but then we do have to look at the pocket of the patient and go, I think, accordingly. Overall, a very nice and a very lucid presentation. Yeah. Thank you.
Dr. Mona, ma'am, we have a question here that what is the role of a combination therapy? That is when you give the DEX implant and anti-VEGF injections together. What are the indications for that? Do you do that in your practice?
First of all, Dr. Ruchir, very nice presentation with good case examples. Just before answering that question, Dr. Tinku, I just like to say that sometimes we are always in a hurry to change the agent very fast. And then very often patient is confused, we are confused, we don't know which drug is working. So I think we need to give it a chance sometimes. Probably ranibizumab doesn't last for very long, but all the, it's like even aflibercept sometimes lasts a little longer than 1 month. That 2 weeks you may not see a good response, you may see it a little later. Just my suggestion is give it a little time before, keeping on jumping between injections. Now regarding combination therapy, it may give you a better anatomical result faster, but I don't think visually there is too much of benefit. And sometimes, yes, you do get extension of treatment. Probably combination therapy is best studied in central vein occlusions, where there have been recent studies which show that combination therapy works. But probably I would reserve it for cases where one thing doesn't work.
Thank you, ma'am. Dr. Lalit Verma, sir?
I think all the points have been covered. The only thing is anti-VEGF still are the mainstay, and I, being an older anti-VEGFs, for me, old is still gold. I do not jump to newer anti-VEGF agents as the first line at all. And Ruchir also emphasized laser is not dead. A lot of patients, more than 50% of patients ultimately we end up doing laser focal as a supplement or as a first line in non-center involving. Very important 3-4 examples he showed was when not to do, which is point to be emphasized. Only 2 situations I wanted to ask Ruchir was that you showed one example of DME with fluoride PDR and you said steroid is the main treatment of choice, which I may slightly beg to differ. And second point was about topical Nepafinac advocating, because Nepafinac and are more often misused than used, for their potential. So these are 2 areas which I thought, are not very universally accepted. And also the combo treatment, which Dr. Muna said, combo again, initially we used to sometimes, combine low dose of, 1 milligram or 2 milligram of IVTA along with, but I don't think there's enough data today to say that combo works better than individual. So there is, as of now, I don't think so. We should encourage combo treatment in DME. Ruchir, can you, I don't know whether.
Ruchir, would you take that question? Dr.
Yeah.
Lalit's query?
Sir, the
Time
fluoride.
yeah, time is not on our side, but I think we can talk about it. DME and fluoride PDR, with steroids as first thing, and
So my experience, sir, has been that there are a lot of patients who developed a crunch phenomena with an intravitreal anti-VEGF agent when there is fluoride PDR, when we need to do just laser, and there is DME along with it. So once I've given intravitreal steroids, the PDR component does not go away. We can still do slow laser to control the contraction of the vessels, but the DME will go away. So it may not be the first agent, but in cases where we expect a crunch to happen, their steroids may be very useful for managing just the DME component and not the PDR component.
see, once we talk about crunch phenomena, crunch normally happens once there is already a proliferation or a whitish component coming there. With only new vessels there, whether it is fluoride, what Saurav also had shown, I normally do a combo of laser and anti-VEGF, because laser start doing laser and then add anti-VEGF, because anti-VEGFs have property of angioconstriction as well as managing the DME part also. But steroid, because these are not inflammatory states that you inject dex implant or even IVT.
Right. So my only point was that because of the risk of that, if we see that an imminent situation where we should not be giving anti-VEGF, there is significant PDR. For those cases, steroids may help. But I do get your point that we start with the laser. We can just change the sequence, not give anti-VEGF first, start with laser and then give anti-VEGF.
Remember in PDR, ultimately, whatever anybody may say, there's a lot of protocols, pharma people going to push anti-VEGF. In PDR, laser is what is ultimately going to save that eye forever.
Yes, sir.
Thank you. So with that, we move on to our next talk. The next talk will be by Dr. Vaibhav Sethi. Dr. Sethi is a VR consultant at the Arunodaya Deseret Eye Hospital at Gurugram, and he'll be talking on proliferative diabetic retinopathy with and without vitreous hemorrhage management pearls. Dr. Vaibhav?
Thank you very much, Dr. Tinku. Is my voice clear?
Yes, it's clear, and
Yes.
we can see your slide.
I'll be taking over from where Dr. Lalit Verma sir told us that laser for PDR. So exactly, old is always gold. So if you have a look at this patient, this was a middle-aged man who came to me, and looking at it at a simple glance, you would not feel that this patient has any severe problem, but except for maybe a moderate NPDR kind of status. But if you see the cotton wool spots, it's always important to examine in high magnification, maybe using a 78 diopter, 90 diopter lens if you miss something. But what you see here is you see these small vessels. Now, these vessels are not following the order like a normal vessel should do. They're crossing the major vessels. These are new vessels. So this is the crux of the talk, that proliferative diabetic retinopathy may not always be fluoride. They may be featureless PDR, in which cases you have very mild features and you might very well miss these features, and the patient might later on come back on a follow-up with a bleed. FFA or angiography is the gold standard in cases which shows you very beautifully the new vascularization of the disc, new vascularization elsewhere, the brightening up of the microaneurysms, and the capillary non-perfusion areas. So a wide field color picture and wide field angiography are very, very important because they've improved our understanding on the ischemia up to the periphery. So these are very important modalities that we should use in our armamentarium, especially when we have a doubt if it's a PDR or not. And angiography also gives us a very good idea about the macular perfusion because such patients do also have DME. And with treating this DME, is it going to be of value or prognosis for the patient or not? Will this kind of picture will tell us very clearly because this you can see there's a broad and avascular FAZ, which indicates a severe macular ischemia. So this patient may not do very well even if you treat the patient rigorously with anti-VEGF agents. FFA also has a role in case the patient comes up back for a follow-up, you see new vessels, you're not sure whether these vessels are active or they're going to bleed. So in that case, when you do an angiography, you do find that these vessels, if they lighten up and they do show us leakage, then that area needs to be treated. And you also find out new CNP areas which you have missed out, which requires laser. OCT is also an interesting and useful tool because it gives you the configuration of the neovascularization. This is an OCT article shows that the NVD has different configurations and also tells you about the vitreous, the overlying vitreous, what is the status of the PVD, whether there is any peripapillar traction, and how is the macular traction. So you can always, in case you're planning for a surgery, these tools are very important to know where the plane of dissection would be. And OCT for any NVE will also tell you about different aspects. One aspect would be the configuration, the flat NVEs, how much vitreous extension there is, associated vitreous hemorrhage, and tabletop NVEs that you can see in figure F. So OCT-A is a very useful tool. The reason being that it's non-invasive, it's quick, and it's able to give you very high reproducibility when you compare it with the gold standard FFA. So in case it's available, it's a very good tool to use. As you can see, this article which compared the FFA on the right side with the OCT-A image on the left side of the B scan has very good configuration, and the repeatability and predictive values are very high, up to 95% of the NVEs. So the areas which you can see very clearly, the only thing is you don't find frank leakage because that happens only on an FFA and not on OCTA, but you can very well see the configuration surrounding capillary non-perfusion areas. So that can be very well seen and evaluated in such patients. Quick and non-invasive, better tool for diagnosis and monitoring of PDR. And especially the ultra-wide field technology has opened our eyes, and even as an education tool for the patient and the relatives, it becomes a very, very good tool to assess and how you have done your treatment follow-up for the patient. So let's go to some PRP pearls. So the choice of laser would be double frequency Nd:YAG laser, one of the most commonly used lasers. And there are three laser delivery systems: the slit lamp, the LIO, laser indirect oscilloscope, and the endo laser intraoperatively. Prerequisites would be an informed consent, which is very, very important. We must explain to the patient about all the effects that the PRP can have with a dilated pupil and topical anesthesia. The important thing, I will not go into too much detail about lasers because this has been covered by my colleague, Dr. Sharath, in the next talk. But the important thing is when you're using a slit lamp delivery with the contact lens, the important parameters you must keep in mind is the image magnification, how much your image is magnified when you're doing the laser, what is the laser spot magnification, what is the static field of vision when you're seeing in primary gaze, and what is the dynamic field of vision you will have if you tilt the lens on either side. The laser parameters could be a spot size of 200 to 500 microns with a duration of 0.15 to 0.5 seconds, depending on how strong a burn you want. An interval of 0.2 to 0.6 seconds, power of 140 or below, up to 250 and beyond, and depends on the media clarity and other parameters. And the aim is to create a moderate intensity threshold burn. It should not be too low and it should not be too heavy. So each burn should be around one burn width apart. That is what the correct way of doing a PRP is. From the arcade, you go towards the periphery. That way you're demarcating the arcade. And as you move towards the periphery, reduce your power because the retina there is thin. So you may have, and already very heavy burns are not required. As you move to, if you're doing towards the macula, especially that area, reduce the spot size because that helps and the burn size comes down. And what you can do is that way you have a less amount of energy dissipated. Around 900 burns or so are required in each half of the retina. Around 1800 to 2200 burns would be required to complete a PRP. Or better to start always in the inferior half, because if the patient bleeds, which can happen very commonly in PDR patients, at least you have cleared the inferior part, and you're clear to do the superior and the nasal temporal quadrants later. Temporally start around 2 disc diameters away from the fovea, and it would be a comfortable thing to first make a demarcation line and then proceed temporally. So you know where you don't want to cross over, and then you continue peripherally. Keep around half to 1 disc diameter away from the optic nerve head. Don't be too close. And keep at least 2 disc diameter away from the fibrovascular proliferation or the very large florid NVEs, because this avoids traction or contraction of these membranes. Dynamic tilting of the lens can be utilized to laser up to the far periphery, and PRP should be completed around 2 to 3 sessions as per the patient can take. Avoid laser over parietal hemorrhages. That's important because you will unnecessarily cause contraction, and which can cause further complications in the scenario. Avoid completing PRP in one session because too many burns can cause complications such as choroidal effusion. And too much heavy burns and too many burns can cause these problems. Keep a gap of around 1 week in between sessions and treat both eyes in each session. So this was a patient that came recently. So this is both eye having PDR. Left eye had a fibrovascular proliferation with a nasal traction as well, and patient had DME as well. So the first session, how I treated I treated the inferior quadrant, and I did a nasal PRP as well. But what you can see is I made sure that the left eye don't go too close to the fibrovascular proliferation in the traction area, because that is what I would like to avoid. Then, secondly, in the second session, a week later, I completed whatever I could superiorly, and in the other eye, I could also complete some temporal area as well. And in the third session, the patient will be coming back for follow-up. I will plan to complete the leftover area in the right eye and the skip area that is there temporarily, and some area not very close to the traction, but keeping around 2 disc diameter away from the extent of the TRD and the fibrovascular proliferation to avoid contractions. This is very nicely shown by Dr. Manish Nagpal's picture in Retina Image Bank, where extensive PRP can sometimes, with high power and parameters, without giving too much time, can cause choroidal effusion, seen very beautifully here. LIO can be used in cases of media opacities, dense cataract, vitreous hemorrhage cases, and important when you want to target more peripheral areas, supposing there is still recurrent vitreous hemorrhage, or there is still active NVEs and NVEDs despite good enough laser, and there's some CNP areas in the periphery, you can use the LIO to indent carefully and laser up to the aura as well. And especially patients who cannot sit, who are morbid. Anti-VEGF therapy has a role in PDR, but what is the role? There is definitely a role in PDR with DME, as Dr. Lalit Verma sir told us very clearly. But it's important to understand that anti-VEGF should not be taken as monotherapy in treating PDR. It also has a role in high-risk PDR cases to tackle aggressive vascular NVEs, and it should always be used along with the gold standard of care, the PRP. Protocol S of DRCR study showed that anti-VEGFs are not inferior to PRP to treat PDR. But the problem is we have to apply it in our real life scenario. It's not practical. Patients need long-term close follow-up, cost of multiple injections, multiple hospital visits, and risks of repeated intravitreal injections are there. Even in Protocol S, where this was done very diligently, which maintained the highest standards to ensure the patients come back for a follow-up, attend each visit, 39% of patients did not comply at 5 years. So how long will you keep treating with anti-VEGF alone? PDR with DME, definitely, you can plan an anti-VEGF injection along with your PRP sessions to tackle the PDR and DME together. It can be given before, in between, and after the sessions, as per the patient's convenience and as per the diabetic status and the severity of DME. PDR with vitreous hemorrhage. So this is another entity in which the DRCR protocol has told us that 46 to 48% of patients who were treatment-naive PDR cases that were treated with PRP and anti-VEGF agents respectively, they developed vitreous hemorrhage during their course of follow-up over 5 years. So it's a very important entity that we must keep in mind. B scan is a very important tool in case if there's dense vitreous hemorrhage is obscuring the view, because you need to check for the vitreous status, whether it's detached or incompletely detached. You must check for tractional retinal detachment and focal traction points. Check for fibrovascular proliferation, because these points later on will help plan your surgery from where you're going to be starting clearing the hemorrhage. Traditional management always says performing PRP in visible areas of the retina when the vitreous hemorrhage clears off, and wait for spontaneous clearance before proceeding with further PRP. Vitrectomy, which was reserved previously, without spontaneous clearance for up to a period of even 3 months of observation period, or in cases of earlier, in cases of recurrence of hemorrhages. But the main reason behind this approach was the DRVS, the diabetic retinopathy vitrectomy study done in 1985, where they compared early PPV versus delayed vitrectomy in vitreous hemorrhage for PDR, and they had shown that early vitrectomy that time had significantly higher post-operative complications, up to 40%, leading to significant visual loss. So it was not considered a entity to be done initially. But with MIVS, with smaller gauge VR surgery, now we know better fluidics, more efficient systems, and better viewing systems. The surgery is safer and has better outcomes. This study done this month in AJO, published in AJO, this has compared early pars plana vitrectomy versus delayed pars plana vitrectomy in patients having the first episode of vitreous hemorrhage in PDR patient. This was a retrospective analysis of type 1 and type 2 diabetics, and it excluded patients who had had prior vitrectomy, who had macular edema, and who had presence of traction or rhegmatogenous components of detachment. So just plain simple first time vitreous hemorrhage. And they had compared early vitrectomy within 6 weeks and delayed vitrectomy after 6 weeks, comparing the baseline vision and at 1 year. And the other secondary parameters they compared was reoperation rates and severity of complications. 178 eyes were studied, out of which 48 eyes were in early vitrectomy group and 130 were in delayed vitrectomy group. So the mean time when the patient was operated in the early vitrectomy group was around 3 weeks, 3.36 weeks to be precise. And in the late vitrectomy group, delayed vitrectomy was around 22 weeks. The baseline vision was similar, and at 12 months, the early vitrectomy group tended to have significantly better vision outcomes with fewer sight-threatening complications. So the important thing was this study did show us that there were benefits of early vitrectomy in cases of simple hemorrhage, which did not improve within because they operated after 3 weeks of waiting, having early PPV done. An interesting observation was the PVD status. So PVD status is an important tool when you're going for a vitrectomy in PDR cases, because if mostly there is incomplete or no PVD, and when there's no PVD, this actually acts as a scaffold. And with the thickened posterior hyaloid, it exacerbates fibrosis, leading to traction. And this traction in TRD and causes recurrent vitreous hemorrhages as opposed to that. Previous PRP can also be a challenge while doing a PVD induction in that area because of the adhesive effects of the PRP on posterior hyaloid. So PVD itself is a long-term stabilizing effect in diabetic eyes. Is anti-VEGF an option in cases of vitreous hemorrhage PDR? The DRCR protocol AB study compared early vitrectomy versus aflibercept in patients of PDR with vitreous hemorrhage. And though they did not find any significant difference in the mean vision at 24 weeks, but on post-hoc analysis, on looking in detail, the lower vitreous hemorrhage recurrences and neovascular rates in the early PPU group were there, with no TRD development, as compared to around 10% in cases of the aflibercept group. So the take-home message would be careful examination. That's very, very important in cases of PDR, because there are cases of having very minimal features where you have to subtly look at the area, especially around the arcades and nasal to the disc, because that area you sometimes tend to miss, and you have those subtle NVEs. In case you have a doubt, do an angiography, if you have an OCTA, do an OCTA, which will give you a very good idea of the non-perfusion area and will brighten the NVEs will brighten up. PRP and PRP is the treatment of choice in PDR. Anti-VEGF agents do have a role, but not as monotherapy. So in cases of vitreous hemorrhage, I normally do a 3 weeks observation, around 3 weeks, and do an accessible PRP in case the vitreous hemorrhage is clearing. In case not, an early vitrectomy does have a beneficial role. in cases you can manage properly. Do not delay vitrectomy in cases of non-resolving vitreous hemorrhage. This is the crux of the presentation for general ophthalmologists. So if you get a patient with vitreous hemorrhage, don't think just waiting on it will improve the chance. There are higher chances of having a progression to tractional detachment and vision loss, even if you do the surgery. So surgery should be planned earlier with the help of a retinologist. Anti-VEGF therapy is an alternative in cases of vitreous hemorrhage, but again, there is a higher chances of recurrence and TRD formation. So it's not going to be treating the source cause. You have to finally do PRP, and that requires a vitrectomy. Thank you very much.
Thank you, Dr. Sethi, for highlighting some very, very important points. Just very quick comments from the chairpersons. We have a question here, Dr. Lalit Verma, sir. What would be your time period before you advise a patient to go in for vitrectomy? How much would you wait?
It is the vertical follow-up which will tell. Suppose I see a patient like I saw 3% today. So I've, asked them to position and do other things. And I see him after a week or 2 weeks. If the trend is, say, improving, I may wait further, or especially if the macula is, on and not detached, then I may. But if the macula is off, then I think there's no point waiting. So it depends. If you're talking of plain simple vitreous hemorrhage, then vertical trend will tell you after a week, 2 weeks. If it's improving, then you can wait. But if not, then my threshold of intervention is not in months, is in weeks, like Vaibhav Sethi said, because early vitrectomy always gives better results. Plus, you can do extensive laser during endo laser at that time.
Mona ma'am, any comments before we move on?
Very nice and crisp presentation, Vaibhav. I would just add a couple of comments. One sitting PRP per week may not be very practical, except if the patient is from your own hometown. So sometimes we may need to do it every alternate day or every day, in which case we can give the patient topical steroid for a short period of time to counteract the choroidal detachment. Another thing is, if there is any peripheral lattice or breaks, I would prefer to treat them along with PRP, because especially when we are likely to give injections repeatedly, the chance of disturbing the vitreous and that causing a problem. And all vitreous hemorrhage in a diabetic is not PDR. It's important to look at the periphery. There may be a horseshoe tear or something, especially if there's no diabetic retinopathy in the other eye. We don't assume that every vitreous hemorrhage is PDR in a diabetic.
Oh, true. Dr. Saxena, sir?
Yeah, very nice presentation. And I feel that judicious use of a combination of laser and anti-VEGF agent remains the best sort of a treatment for proliferative disease. And laser is perhaps the best anti-VEGF, which we know of, and that has a lasting value. So I think we should do a judicious use of both. And regarding surgery for vitreous hemorrhage, I think if things are not improving, as Dr. Verma said, then I think between 3 to 6 weeks would be a good time. And this time also gives you or the patient time to get himself metabolically controlled also. Because if we are going for surgery without a good overall control, things will not go the way we plan to do. Yeah.
Thank you. So
Can
we
I
now
can I
have.
come in? Can I make a quick comment, Tinku?
Yes, sure, sir.
Yeah, to add to what Dr. Vaibhav said, I would use FFA also in situations where there's asteroid hyalosis with a very dense asteroid not allowing us a good view of the fundus. And we know that asteroid doesn't liquefy, the vitreous in asteroid doesn't liquefy, and setting up an ideal situation for florid forms of PDR, and those are poor candidates even for surgery. So that is one situation where we would use FFA, and also in early vitreous hemorrhage in one eye and maybe mild to moderate PDR in the other eye. Even through the hemorrhage, many times we can pick up the new vessels, thereby establishing the diagnosis of PDR on firm grounds in the involved eye, and also uncovering early PDR if it is there in the other eye. As far as laser for patients with vitreous hemorrhage is concerned, I will use this technique of letting the patient close the better eye and then taking a view with the eye with hemorrhage. And if he or she finds that the clarity is better on a certain day, to come back the same day rather than giving them fixed time that you come back after 3 weeks and 4 weeks and all that. Because many times they will say that I had better vision on the 10th day, but since you asked me to come 3 weeks later, I came. So we'll be missing a chance to do laser. So that is one thing I employ.
Thank you, sir. Thank you for those tips. So with that, we move on to our next talk by Dr. Sharath Hegre. Dr. Sharath is a VR and UVR consultant at the Prasad Netralaya, Udupi and Mangalore. And he'll be talking to us about lasers in diabetic retinopathy, when and how to do. So Dr. Sharath,
Yeah. I thank AICRC and Dr. Tinku Bali for giving this opportunity. As the other chairpersons, all the chairpersons and other speakers have told the importance of lasers in diabetic retinopathy, I'll be telling mainly how to do and part of when to do the lasers in diabetic retinopathy. So I'll be covering mainly the mechanism in retinal laser and the indications of laser and what are the settings and how we do the laser, and some common doubts I'll be covering in the later part. So laser stands for acronym for light amplification stimulated emission of radiation, which works on the central concept of converting the electric energy into high energy density beam. So through stimulation and amplification. So it has many properties, especially the monochromatism, where it emits the light only in one wavelength, which are all in the same phase and in a single plane and in one direction. So these properties give it a property of very high energy, which can be sent into a very small area. So previously they were using 810 nanometer diode laser for doing the lasers, but nowadays most commonly we have shifted everyone to double frequency NDI green laser. And for the subthreshold laser nowadays we are using 577 yellow laser also. So how it works in the retinal lasers? So whenever we leave the retinal light to the target tissue, it generates the heat and it denaturates the protein, or it coagulates the protein, and the process called as photocoagulation. So both the pan-retinal photocoagulation and the focal laser works on the principle of photocoagulation. So before going for any lasers, we do certain investigations like doing a fundus photo, fluorescent angiography to look for any capillary non-perfusion areas, or what type of focal leakage is it? Is it a focal leakage or is it diffuse capillary leakage for the presence of diabetic macular edema? Also, we do a OCT to see amount of macular edema, and nowadays the OCT angio also can be done to look for the capillary non-perfusion areas and the neovascularization. So what are the main roles of laser in the diabetic retinopathy? So mainly is the pan-retinal photocoagulation, along with that grid laser, focal laser, and nowadays we do subthreshold laser also for certain non-resolving diabetic macular edema. So coming to the indications of pan-retinal photocoagulation in the case of diabetic retinopathy. So as everybody knows, we do mainly in the high-risk proliferative diabetic retinopathy patients. Along with that, if the patient are very severe NPDR with uncontrolled sugars, especially I take it as HbA1c levels, which is more than 9 or 9.5, and the patient is not able to come far or they're not able to do follow-up, I do after the laser in very severe NPDR. Or the one eye has having PDR and other eye having a very severe NPDR, even then I do the laser. If the patient is having associated ocular ischemic syndrome, that time also I prefer to do PRP in the patients. And especially when there is a vitreous hemorrhage or a tractional retinal detachment, if there is some space is available to do, I like to do preoperatively how much the possible of the laser is possible. So coming to the main principle, whenever you do the PRP, it causes the damage to the retinal cells, and this damage decreases the overall retinal oxygen demand and the retinal hypoxia. This decrease in the hypoxia will cause subsequent downregulation of the angiogenic factors, and it helps to increase the oxygen perfusion in the remaining viable retina. So coming to the PRP technique, the first and foremost, what I tell is you should know about the machines properly before doing the laser, that it will be very comfortable. The delivery system has explained by Dr. Vaibhav. So we commonly use slit lamp system using a contact lens. Along with that, we can use laser indirect ophthalmoscope or the endo laser while operating. And nowadays we have a Pascal laser system where the multi-spot lasers can be delivered, which has the advantage of a faster delivery, improved comfort, and the advanced precision. Also, we can use Navilas, where the previous fundus photo we can give it to the machine and we can beam where the laser spot has to be going. So you should know your machines and settings before doing the laser. So I use usually Zeiss single spot laser. So normally the spot size, the duration, the interval between the spots, and how much the power you are giving, it will show in the screen, and you should be knowing about that. The lenses what we use for the laser, mainly we use indirect lenses like Mainstar or a Volk lens. And I prefer to use for a PRP Mainstar PRP 165 lens, which gives a very large field of view with a spot magnification of 1.96. And for the focal laser, I use Mainstar high magnification lens, which gives the field view of 75 degrees. So before doing a laser, preparation of the patient is important. With the informed consent, the better to try have a fully dilated pupil maximum possible. So apply the topical anesthesia, and patient should be comfortable. If you are doing in a sit lab, keep the proper height for the patient should do a laser, or the indirect laser we can make the patient lying down, and tell them to ask the fixate from the opposite type, which will be easy for you to do a laser. Coming to the regular settings, normally we keep the pulse duration of 100 to 200 milliseconds with the laser spot of 100 to 500 microns, and the power starts from 100 to 750 milliwatts, where it comes a moderate intensity. But my settings usually I keep the pulse duration of 50 milliseconds with the laser spot of 100 micrometers, and the power where it comes the medium to gray white intensity burns I like to do. It has a certain advantages like we do in a Pascal, where it has a lesser pain and the patient comfortability, and this decreasing the pulse duration and the spot size will have a better penetration of the laser. But only issue is you need to give more number of spots compared to the normal number of spots. So when we start the laser, usually we start doing the inferiorly, give one width apart and try to finish inferior part initially, so that if the vitreous hemorrhage happens, we may not be able to do the laser there. I usually try to complete in 2 to 3 sittings by doing the second sitting in the nasal part and superior temporal part, and the third sitting I try to do in the temporal part. You can do also 2 to 3 two sittings, or as the Muna madam said, you can do it next day also to complete it if they're very far. But the most important thing you should know is where to avoid the laser burns. Especially try to avoid the laser burns on the optic disc, fovea, the major vessels, and the neovascular over the neovasculation vessel, and the pre-retinal hemorrhages. Ideally, the laser burns should be slightly moderate to moderate intensity burns, which should be like this image. Coming to the focal laser in the diabetic macular edema, as we everybody knows nowadays, anti-VEGF or the steroids are the first line of treatment. But whenever there is a recurrent macular edema or the extrafoveal microorganisms leak is there, or to decrease the number of anti-VEGF or the non-response to the anti-VEGF, better to do a focal laser. So my settings for the focal laser is the pulse duration of 50 milliseconds with a laser spot diameter of 50 microns, and the power starts from 100 to 200 milliwatts. The grid laser, when we do, it helps to decrease the macular edema via photoreceptor destruction, which increases the inner retinal oxygenation. Similarly, it also helps to retinally capillary venule endothelial proliferation damage, and it will restore the inner blood retinal barrier, and also it will enhance the outer blood retinal barriers. So usually we do a modified grid laser nowadays. Wherever there is the thickening of the macula, we do the laser like just outside the foveal avascular zone. We usually give around 3 to 4 rows of the laser, has the grid laser part. Similarly, the focal laser we do directly on the leaking microaneurysms, so which closes the aneurysm via laser-induced endovascular thrombosis or heat-induced contraction of the vessel wall. It's always better to do a fluorescein angiography to see where is the leaking microaneurysms and do the laser. Here, the 1 or 2 leaking microaneurysms can be directly hit with the focal laser. So the complication has explained, the patient discomfort can be there if the higher power is used, and there can be sometimes the permanent retinal scarring. Excessive laser in the same setting may cause choroidal detachment, elevated intraocular pressure. Directly hitting on the vessels can cause vitreous hemorrhage or combined retinal detachments and cystoid macular edema. Delayed complications can happen like a secondary choroidal neovascularization if the power we use is a bit more, which can cause the break in the Bruch's membrane, or there can be a presence of subretinal fibrosis and the ERM formation. And sometimes this laser, when we do a focal laser or a grid laser, it can extension of the spot size can happen, which is called as laser creeping. I won't touch more on subthreshold laser, but nowadays we use this micropulse technology where the laser energy is delivered through a train of repetitive short pulses. And these short pulses will decrease the heat produced in the retina, and it will help to prevent the burns. Visible burns is not visible, but they say that it activates the retinal pigment epithelium and it decreases the diabetic macular edema. There are certain simple questions, but many people they won't want to ask. So, is there a PDR with not? If there is a PDR and no traction is seen associated with DME, when do we start PRP? Ideally, it's better to decrease or treat the DME first, along with anti-VEGF or steroids, and then start PRP. And whenever you're doing the first setting of PRP, you can add with the augment with the grid laser also. If there is a PDR with traction, then how to do? Better to avoid anti-VEGF in these conditions and give YVTA or Ozurdex followed by laser. Is it necessary to do PRP before going for vitrectomy in the cases of tractional retinal detachment? It's not absolutely necessary, but doing the PRP in the available areas will make the neovascularization tissue less angry, and it also saves your time for doing the PRP during surgery. If there is a dense cataract in the PDR, so ideally, if we're able to do the laser, we'll try to do with the LIO at least when with the slit lamp it's not possible. Even with the LIO, if it is not possible, try to give anti-VEGF for steroids along with the cataract, and then do after 2 weeks of later cataract surgery. I tell the cataract surgeon to put a one suture also if I feel that PRP has to be started a bit earlier. So usually we do up to the extent possible of the periphery, we'll try to do the laser, but at least up to the equator, we need to do the laser. So overall, lasers in a diabetic retinopathy is the mainstay of treatment for PDR or for PRP in a PDR is very, very important, and you can do it in 2 to 3 settings. And a grid laser or a focal laser, usually we do in a case of recurrent DME. I prefer to do slit lamp delivery, which is more comfortable for the patient and even for the ergonomics of the surgeon. And it helps to prevent severe vision loss in a case of diabetic retinopathy. So combination of pharmacological intravitreal medications and the laser helps to achieve optical visual outcomes. Thank you.
Thank you, Dr. Sharath, for those excellent practical pearls that you shared with us. And with that, we'll have the comments later. Since we're running short of time, we'll move on to the next talk. So we have with us Dr. Ajay Agarwal. Dr. Mohit's talk will be after this on cataract. So, there are so many questions that we as ophthalmologists want to know when we want to ask a diabetologist how to manage the patients with these high blood sugars. So today we have with us Dr. Ajay Agarwal, who's the chairman of the Department of Endocrinology and Metabolism at Sir Gangaram Hospital. And he's recognized as one of the leading endocrinologists in Delhi. So thank you, sir, for your presence here this evening. And I'm sure you're going to solve a lot of queries that we as ophthalmologists have when we are managing our patients. So Dr. Ajay, I request you to share your slides and looking forward to your presentation.
Thank you, ma'am, for this kind introduction. First of all, I thank you again for inviting me for this talk. What I will be doing, I'll be telling about management of diabetes. All an ophthalmologist should know. So I have tried to keep it very simple so that if there is any questions, we can tackle that. And as you know, we are clinicians, we learn more from the cases. I'll go over for two cases. First is one lady, 64-year-old. She's obese. BMI is 34 and diabetic for 8 years on oral medication. Hypertension, well controlled on ARBs, that is telmisartan. Primary hypothyroidism on treatment with levothyroxine, well controlled. She is taking aspirin for primary prevention of CAD, and she has come to an ophthalmologist for cataract surgery. Her investigation showed fasting of 167, PP 298, and HbA1c was 9%. So she was referred to an endocrinologist for a better glycemic control. First did was when aspirin was stopped. Why? Because there is no role of aspirin in primary prevention as per new guidelines. Then she was put on medical nutrition therapy. Her lifestyle modification was devised, and her oral medication was devised, and she was put on basal insulin at one injection of glargine insulin at bedtime. After 2 weeks, she came with a daily charting of blood sugar, and fasting raised from 104 to 132, and postprandial was from 148 to 187. So she was cleared for surgery. Then next patient, a 54-year-old male, diabetic for 4 years and hypertension for 3 years, post CABG for last 1 year, on oral medication, glimepiride and metformin, and also on anticoagulants, clopidogrel and aspirin. He has only fasting blood sugar records showing fasting 136, 143, 152, which was on the higher side. He doesn't have any postprandial sugars. He doesn't have any HbA1c. So he was advised to get fasting postprandial HbA1c. Cardiac consultation was done in view of anticoagulants, and they advised to stop clopidogrel before surgery. When endocrine consultation was taken, he was on fasting sugar 140. The reports was fasting 143, ppb is 264, and A1c was 8.2%. The treatment was revised, and patient was continued on the already OHS, and plus a combination of newer drugs, that is DPP4 inhibitors and SGLT2 inhibitors, that is Grixambi. It was added. With that, after 10 days, her sugar was fantastic, fasting 122, 112, 120, 99, and PP was well under control. So this patient was cleared for surgery. So this is a slide for the references of endocrinologists, which shows what are diagnostic criteria for diabetes. In a normal, we have got 3 categories: normal, pre-diabetes, diabetes. Normal is 79 to 99, fasting, PP below 140, and HbA1c 4.5 to 4 to 5.7. Whereas fasting, we diagnose when fasting it is more than 126, ppb more than 200, and HbA1c equal or more than 6.5, or random blood sugar with symptoms. So you can diagnose the patient have diabetes. And in between the two, it is pre-diabetes. So what are the symptoms? We all know it's polyuria, polydipsia, polyphagia, infection which usually take more than usual time to heal, dry skin, blurry vision, and and easy fatigability. So it's just for your kind reference only. We have got a lot of new anti-diabetic drugs, because you must be seeing a lot of prescription patients carrying with them. They're carrying most of the time glycomet GP2 or gluconom G2, which are all commonly used medicines like glimepiride, metformin. Where we have got a lot of new medications which are now available for diabetes, like DPP4 inhibitors, sitagliptin, vildagliptin, linagliptin, teneligliptin. These medicines, they are cardiac safe, as well as they don't lead to hypoglycemia, they don't lead to increased weight, and these are glucose dependent effect. Like these medicine will only help when blood sugar is high, and when blood sugar is normal or blood sugar is low, it won't work. Another group is SGLT2 inhibitors, like canagliflozin, dapagliflozin, empagliflozin. What these medicines do, they cause glycosuria. They inhibit renal tubular reabsorption of glucose. So glucose is passed through the urine. Once these medicines were introduced, with a lot of inhibitions, like this can cause a lot of UTI or candidal infections. But these medicines are wonderful medicines. They not only decrease sugars, but they reduce cardiac events by more than 50%. So a lot of cardiologists, even in the guidelines, they're using these medicines in cardiac patients, those who have not got diabetes. Of course, the concern is UTI and candidal infection, which we have to be careful. Then newer insulins, Degludec, glargine 300 unit. These are long-acting insulins, like they can be given once in 24 hours, but they work for more than 36 hours, so you can give it daily, but at any time of the day. Another good insulin which is coming in the future is Icodec. This is once a day, once a week basal insulin. So patient, if on oral medication want to add insulin, we can just give once a week insulin. Now the another good medicines which are now available, and some of which may be concerning with ophthalmologists, are GLP-1 receptor analogs like semaglutide, tirzepatide, liraglutide. These medicines, they not only reduce blood sugar, but also help to reduce weight. So these medications are even approved for weight loss only, without medication, without in those also who has no diabetes. This semaglutide is available as oral as well as injectable medicines, and this tirzepatide it is injectable semaglutide, which is named the Ozempic. This is a very popular medicine worldwide, but this medicine is not available in our country. Munjaro is going to be launched next month, and I was actually associated with phase 3 trial with all these medicines. And believe me, these are the wonderful medicines. They help the patient to lose weight as well as blood sugar control. Now, something concerning with ophthalmologist. Semaglutide and eyes. A rare kind of eye stroke, you know better about this, non-arthritic anterior ischemic neuropathy. NIN, especially in the first year of use of this medicine, is encountered. So if you're starting this medicine, we have to caution the patient about this condition. Second thing is there is worsening of retinopathy. There may be short-term changes in the vision. The patient may have blurred vision, particularly in older patient, when we begin this medicine.
Webinar.
Anticoagulant and eye surgery. You know, a lot of patients who come for the eye surgery, they are on anticoagulants. It may be clopidogrel, it may be aspirin, ticagrelor, warfarin, and NOAS like apixaban, new oral anticoagulant, dabigatran, rivoxaban. In one study, it was found that 25% patients who come for surgery, they are on aspirin, and 4% patients are on warfarin. So the question is, should these anticoagulants be stopped for surgery? Yes, other than aspirin, other anticoagulants can be stopped before surgery. Warfarin, if we need to stop warfarin, we can put patient on heparin. Aspirin can be continued during surgery. And these new anticoagulants like apixaban, dabigatran, rivoxaban, you can start 1 to 2 days prior to surgery and start maybe 2-3 days after the surgery. So this is a study from China, published in Journal of Ophthalmology, continuation of aspirin therapy before cataract with different incisions. What are those different incisions? You know better than me. And it was seen there is no significant difference. There were 3 groups. One was without diabetes. Other was in those whom clear corneal incision was given, and one in which another incision was given was I don't know what incision, you may know better than me. It was seen the patient who were with clear corneal incision given, even if aspirin was continued, there was outcome was reasonable. So we can continue with aspirin in these patients who are on this antiplatelet even during surgery. Now, what to do when patients come to you for the eye surgery? Definitely, history of diabetes has to be taken. Even if there is no diabetes, always check fasting PP sugars. If there is diabetes, then we can check fasting PP sugars, HbA1c, and if high, definitely we have to take clearance from physician or endocrinologist. And one more thing, a lot of patients come to us and they say, my ophthalmologist said, you just bring one sugar value below 200, it's okay. But we always tell them single value of blood sugar in normal range is not sufficient. So what is the concern when there is poor glycemic control? It leads to poor outcome like infection, post-op inflammation, and delay in wound healing. Then how to manage diabetes on the day of surgery? Better I know you people take that patient early in the morning and tell the patient to bring light breakfast. Maybe he can have a cup of tea or some light breakfast at home, and he come to the clinic, get the surgery done. He should be told to avoid anti-diabetic medicine, like even insulin. And once after surgery, he can take anti-diabetic medicine with food. And we should advise them to monitor blood sugar more frequently, keep a track. One more thing. There is no evidence to suggest there is adverse effect of high intraocular glucose on outcome after of cataract surgery. Another thing is we should not try to reduce blood sugar very fast, and it may actually worsen retinopathy and maculopathy. Now, sometimes you may encounter patients hypoglycemia in your clinics that we should be able to identify and treat the patient. Like most of the symptoms include shaking, sweating, dizziness, fast heartbeat, irritability, hunger, and headache. In such cases, we should have glucometer at our clinics. We should check the blood sugars, and if sugar is high, definitely give some glucose or even common sugar to these patients. Then another good point is, sometimes patient come to the clinic for surgery, and he may have high sugar at that point of time. But if his control is okay, for long-term control, like HbA1c is normal limit and his sugar is range from 70 to 216, then it may be appropriate to proceed the patient with surgical procedure. So no need to postpone the procedure. Even single one high sugar is not a deterrent for the surgery. Then another medicine which we are using in our clinics, one is pioglitazone. It is a group of thiazolidinedione, and in a study published from Japan, studies presented from Japan in European Association Study of Diabetes, it was seen this drug significantly increases the risk of macular edema 5 times greater than not on pioglitazone. Another point was, if combined with insulin, the risk of macular edema increases more than 11 folds. Then another problem we people are connected is thyroid eye disease. A lot of patients, we come to us, we refer to an ophthalmologist, and they send us back like patient needs high dose steroids sometimes. If the patient needs high dose steroids sometimes, maybe patient has got already pre-existing diabetes, or maybe steroid can induce diabetes. In such patients, we need to monitor blood sugar, and we need to refer it for blood sugar control. With that, thank you very much. I think I was very basic. I have told you things. If there is any question, we can discuss.
Thank you, Dr. Ajay Agarwal, for that excellent exposition and for those, wonderful things that you told us, especially about new anti-diabetic medicines and things that we should keep in mind while taking up a patient for surgery. So the panelists, would you have any questions for Dr. Agarwal or any of the speakers? Anyone would like to ask something?
Thank you, Dr. Agarwal. That was an excellent talk, and a
Well,
lot of things, especially now with Ozempic coming up.
Ma'am, Ozempic will not be available in India.
No, I had a patient actually who got it from outside, and
It's available in the grey market, but it's not officially available. Tirzepatide is going to be available very soon.
So is there
And
something we
tirzepatide is
need to
better than
be,
Ozempic.
is there something we need to be concerned about?
Tirzepatide, we don't have any data to suggest any eye problem, but Ozempic, definitely we have got that anion, and that we have to keep in mind, but it's extremely rare.
Another question I had about pioglitazone, because sometimes there are two diametrically opposite groups of diabetologists. And if we say, can we switch from pioglitazone? Some of them do it very readily. Some of them say no. So
Actually,
legally, is it
pioglitazone,
still, is it in between? There was a talk about a ban on the drug. Is it there, or is it still used? Or
pioglitazone is a good medicine. But the problem with pioglitazone is three problems. One is it causes weight gain. Another is causes osteoporosis. Third is high dose, it can cause CA bladder, urinary bladder. So, in normally in endocrinologist practice, it's very much low on the list. We generally don't like to use it. And sometimes, the problem sometimes is patient is taking pioglitazone, he comes with very good sugars, so it becomes very difficult to stop it. And once or twice I have burned my hands. I put a stop pioglitazone, sugars not like anything, and we again have to start. So given a choice, I have so many other options. I would like to not to use it.
thank you.
Thank you, Dr. Agarwal. Just one quick question. What are the fallacies in HbA1c measurement? Like, when do we take HbA1c with a pinch of salt?
Sometimes there is few occasions we see patients who have got normal blood sugar but HbA1c is high, who have got high blood sugar but HbA1c is low. The problem is when the patient we need to see what is hemoglobin level. If hemoglobin level is low, HbA1c can be falsely low. And there are sometimes hemoglobinopathy like HbS, hemoglobin S, or hemoglobin C. In those cases, it only falsely high HbA1c. It can be falsely high HbA1c. Sugar is okay. So in those cases, if there is not correlating, then we may need to go for either fructosamine test, which gives us for 2 weeks blood sugar record, or we depend upon the blood sugar charting. So we have to correlate these two things. What blood sugar charting is, what HbA1c is, then we can take a decision.
Thank you. Thank you, Dr. Ajay. Thank you for your presence here this evening. And it was really nice listening to your talk. And thank you so much.
Thank you, ma'am. Thank you.
So with that, we move on to our next talk. That will be by Dr. Mohit Khatri, who is a consultant ophthalmologist at the Regency Hospital, Kanpur. So Dr. Mohit would be speaking to us on cataract surgery in a diabetic patient. Dr. Mohit is a retina specialist as well as a proficient cataract surgeon. So I think he's just the right person to speak on this. Dr. Mohit, over to you.
Thank you, ARC, and thank you, ma'am Tinku, for involving me in this meeting. I hope my slides are visible.
No, sir, you need to share again, please. Just click on the share screen button below on the Zoom window. You still not started.
I'm trying. It's not
So you have the
allowing
green
it.
button 6 o'clock, which says share.
Yeah, I did that.
Are you on a Mac?
No.
Just click on the green button. There will be a pop-up. Just press the blue button.
I did so. And is it coming now?
No, sir. It's not coming. Have you pressed the green button?
Yeah, obviously.
Do you have a pop-up?
Share screen I am doing, yeah. And
there's a pop-up?
Yeah, I think now it's
Yes, now it is coming.
It's coming?
Yes, this
So
yeah.
visible now?
Yes, just make it into slideshow mode, sir. That's it.
Yeah, correct. So sorry for that glitch. And next few minutes, I'll just be giving my few cents on cataract surgery in diabetics and what all a cataract surgeon should have in mind. So that's very interesting topic and a very pertinent issue now. Why is it important actually? Because these two things are interrelated: the diabetic retinopathy part and the cataract surgery part. Cataract surgery is going to worsen diabetic macular edema, and diabetic retinopathy jeopardizes the outcome of cataract surgery. So whatever you promise to the patient might not be deliverable because of the presence of diabetic retinopathy. So one more thing is that cataract obtures the fundus view and hinders an imaging or management of diabetic retinopathy. So you need to take it out early if you want to do laser or something more. So doing cataract surgery is not just a job here. Other surgeon might need to contribute. So we need to have a good ground available for the next surgeon to pitch in. So if there are two different surgeons, so that again gives you an add-on responsibility to do a good job. And medico-legally, it is very important to look for diabetic retinopathy in presence of diabetic cataract patients, and we must document it. So take this point very important, that note the diabetic retinopathy presence if it is in a diabetic before operating upon cataract. So when you see the patient in your clinics, in your OPD, so very important is to take the history of the duration of diabetes and the pattern of blood sugar levels. This gives you a clue of what's happening and how good is the control of the patient and how good he's going to behave in future also. And one very important question is going to be how the vision has dropped. If was it a sudden drop or it has an insidious onset. So that gives you a clue what worsened. Was it macula that worsened? Was it bleed? Was it cataract? So this is a very important question that one must ask. And history of treatment, you must instigate upon the attendants and the patients. Often they hide. Try to get all the records. Has somebody given an injection? Has some laser been done? Because that is going to help you to prognosticate the case and maybe to raise the red flags, and also see the comorbid conditions like CVAs, the diabetic foods, if the creatinine levels are high, or the treatment history part. So if other comorbid conditions are there, you must be having some retinopathy. If there is a dense cataract, then still suspect some kind of retinopathy in this kind of patients. When you examine the patients, always and always see if your best corrected visual acuity is corresponding with the grade of cataract. If the grade of cataract is less and you find a finger counting patient, that means something wrong is behind. Have a red flag again. See the presence of any obvious cranial nerve palsies. Often these patients develop a sixth nerve or some kind of cranial palsy, and you operate upon cataract, they develop diplopia, and you land up in a soup. See the lid margin very carefully. This is the source of all the terrorists that might creep in and give you a big endophthalmitis. So in these patients, they are more prone to develop such kind of infections. Be very cautious. Look at the corneum clarity. If there are epithelial bully, if there is something like an NVI, be very alert. You have a big problem inside. So if the cornea is hazy, be a very critical analysis person out there. And in your OPD, try to give the maximum opportunity to these patients to see how much they dilate, because often the pupil doesn't dilate as good as you want in these patients, and then there is a problem during surgery. So don't be in a haste to see these patients. Give them appropriate time to sit back, relax, and try to see what maximum pupillary dilation you got during the pre-op workup. If you get an NVI, even the smallest of splinter near the sphincter, do a gonioscopy, see the angles. And yes, if you see the macula, never forget to see the periphery, do an indirect as well as 90D both in these patients, and see the disc very carefully. Often we see the macula, we see the cataract and go ahead. But then there might be, AIUNs, human diabetic papillopathy, maybe glaucoma hidden. Always and always be a very critic on the disc also. See the IOP and then proceed. Now, what tests you need? Dr. Agarwal did a wonderful job to tell us how to see the sugars, so not going into much of the details. The AIS task force says that get the blood sugars done a week before the surgery, within a week rather, and the fasting should be less than 140 and PP less than 200 as I follow. Never go on one reading. Yes. Never, just rely on what patient says. हम तो चेक करते ही हैं, सब ठीक रहता है. Get it on paper. Get a blood sugar done on paper from a good laboratory. Then in all diabetics, I get a OCT macula done. I might be overdoing, but yes, I do, and I suggest everybody to do. Many surprises often you get. One surprise a month, one surprise in 3 months. Okay, but then I get OCT macula done for all my diabetic patients. If there is disproportionate vision findings, if the vision is not corresponding to the grade of cataract, then yes, an FFA to look for an ischemia if it is there. In very dense cataract, yes, I do order a specular that helps me to plan if I go for an SICS or if I go for phaco, because these patients are more prone to develop a PBK. Then, if fundus is not at all visible, I would definitely go for a B scan to look for any vitreous hemorrhage or any TRDs or any prolapse if I can diagnose. Then, yes, if the patient is vitrectomized, if there is oil inside or if there is vitreous hemorrhage inside, I would be very careful in doing my biometry. And if the patient is single eyed, I would never hesitate to get a conjunctival smear also done for that patient. Now, the IOL considerations, I would always say that avoid all kind of ringed IOLs, all fancy IOLs should be avoided in these patients. It has to be an in-bag implantation. You can respect the toricity, go for torics, no harms, but no multifocals like that, and give a hydrophobic acrylic material to the patient and strictly avoid silicone IOLs. So that's my choice and that's unanimous. So operatively, I would always prefer not to give them a block, for I just don't want to avoid. I just want to avoid that bleed or something. I don't stop aspirin for my clear corneal incisions, and I prefer to do a topical surgery, often augmented with subtenons if needed. And yes, one should be very dexterous for using all kind of pupil expanders, because if the pupil is not dilating well, if there is a rigid pupil or a floppy iris, definitely I would love to use my rings or hooks, and would use a dispersive viscoelastic to give a additional cushion to my cornea. And yes, this is a very important point. I would love to make a large rexis, minimum 5.5, so that the view later on is not obscured. I don't want any capsular phimosis. I don't want any residual cortex. So I just polish the inner side of the rexis, the capsule, and just thorough cleanup of the cortex is must, so as to have a clear cornea, a clear bag, and a good dilatation thereafter, so that even in later phase I can do a good laser and have a good view of the retina. All maneuvers should be done in the bag, and yes, I always give intracameral antibiotics in these patients and ensure a watertight closure. And post-operatively, it is very important in these patients. I give them oral ciprofloxacin and topical NSAIDs. Yes, bit gray zone, but yes, I do give them, and often we don't subject them to an OCT, but a subclinical CME or even a clinical CME is encountered in diabetics, and this topical NSAID might be helpful. So I just put them for 6 weeks or so and look at their vision. If the vision is 6.966, something like that, I stop and give a longer follow-up in these patients. If the vision is dropping, I subject them to an OCT and see what's going on. So if I talk of some specific case scenarios, so if there is diabetes with uh, maybe no retinopathy or a very mild NPDR not threatening macula, I would take it up as a routine case, and a monofocal or an EDOF is given with the topical NSAID as an add-on, and a longer follow-up with an OCT. But if there is NPDR with CSME with cataract, I would definitely prefer to dry up the retina first and then do surgery, the cataract surgery. If the media is very hazy, I go for an Ozurdex with phaco and then see what's wrong and take up a macular edema as a fresh case and have a very tight follow-up even after cataract surgery and look for progression. In case of a PDR with cataract, I would like to document any traction. If traction is present, then a combined surgery might be PPV with phaco with laser is an option. If traction is not there, then phaco can be done with anti-VEGF and quickly do PRP as the media permits. Never ever do a cataract surgery and then just refer. That is going to be a disaster. If there is a mature cataract with vitreous hemorrhage, this again is interesting. I should not be missing out any NVI. A combined surgery, if permits, it is the best option, or an early vitrectomy if needed. An endoilluminator might be helpful for capsular excess, because if there is no glow, it might be helpful. And if early PPV is needed, we must suture the main port so as to help the retina surgeon. If there is NVI, that is again a very important scenario. If the media is good, try to do laser and laser and laser. An anti-VEGF top-up can be given and then a cataract surgery is attempted. But if media is really bad, then give anti-VEGF and then phaco after 5 days, followed by PRP or vitrectomy if needed. At the time of cataract surgery, if the pressures are high even after a maximum anti-glaucoma, then yes, a TRAB or an AGV can be combined with phaco. So these are the scenarios, very easy to say, but then always there are gray zones. One has to tailor the regime. So to conclude, I would say we have to walk an extra mile with these cataracts. Always keep in the loop your physician and a retina colleague. Suspect more, document appropriately, and counsel and counsel and counsel. Try never to fall in any soup. Never promise more, deliver more, rather promise less. And be very meticulous with your surgery. Give extra chair time to these patients, and always be prepared for surprises. Thank you.
Thank you, Dr. Mohit. That was indeed a very comprehensive and complete talk, and you shared some excellent clinical pearls that every cataract surgeon should keep in mind before taking up diabetic patients. So, a quick question we have on our chat box. What is the role of topical NSAIDs in the early post-op period when the patient is already on topical steroids?
See, after I taper down my prednisolone, then I give them nepafenib. Not before 15 days, but as I'm going to finish off the steroids fast, these nepafenib drops be continued for more than 6 weeks. So they are just a kind of replacement as an anti-inflammatory drug. Both of them starting together is not a very prudent approach.
Okay, thank you. So, Muna
Antibiotics,
ma'am,
topical antibiotics, the prednisolone is tapered and nepafenib.
okay. Muna ma'am, if there are any comments, otherwise we'll move on to the debates.
A very nice talk, Dr. Khatri. I think you covered all things that are essential. And I think we're running late, so maybe
Yeah.
we should move on.
Okay.
Yeah.
So our next section are the great debates, where we have two debates today. So the first debate would be on the management of PDR. So, whether we should manage PDR with anti-VEGF agents or by laser alone. And we have two young vitreoretina surgeons who will be, debating. So we have Dr. Anurag Badani, who's a vitreoretinal specialist at the RPI Institute, Delhi. And countering him will be Dr. Saurabh Verma, who's an assistant professor at the RP Center, AIMS. So first, Dr. Anurag Badani will be speaking on anti-VEGF in PDR. So
Hello, am I audible?
Yes, your slide is visible.
So good evening, everyone. And after the amazing talks by everyone, we already must have come to a conclusion that it is very hard to defend use of anti-VEGF in PDR. So I'll still try my best, and there are no financial interests to disclose. So there are very limited options for us to manage PDR cases, PRP with or without anti-VEGFs. And vitrectomy is reserved for advanced PDRs. But PRP comes with a price. There are lots of already have been discussed. There is loss of peripheral vision. Chances of development of DME after lasers is higher, and long-term complications like contrast sensitivity and night vision problems are always there. And sometimes inflammation can lead to ERMs and other macular anomalies in the long run. And the patient is mostly at discomfort during and after the procedure. And always it is not in the long run, the scarring of the retina in after doing a heavy PRP can leave behind more symptoms like these. In some cases it is very difficult to do a good PRP, as we know that if PRP is not complete, then it is as good as a naive patient not receiving treatment. So in media opacities and in cases where the patient is not ambulant and has difficulty maintaining sitting posture, then doing a laser becomes impractical. And meanwhile, anti-VEGFs have been revolutionizing retina practice across other pathologies like NVAMD, DMEs and ROPs, where gradually lasers have been replaced partly by injections, because our aim has been shifting from preventing vision loss to improving vision outcomes to now prevent disease progression by early intervention in these cases. So options are limited at present, and ranibizumab and aflibercept are already cleared by the FDA for use in diabetic retinopathy to decrease progression of the disease. And anti-VEGFs have been, there is no dearth of evidence showing that they can be used as primary monotherapy or as an alternative to PRP, and sometimes adjunct to PRP or vitreous surgery with good surgical outcomes and long-term vision is also better. So protocol S in DRCR network has already told us that that eyes without DME at baseline, might need around 7 injections in the first year, and reduced number of injections in the second year, with better visual acuity letter improvement after 2 and 5 years, and significantly less of peripheral field loss, need for vitrectomies, and even the development of DME chances are significantly less. And similar outcomes were seen at 5 years, after this. And in some cases, it has also been seen that more than almost half of the patients having PRP also need second sitting of PRP or injections to tackle DME and other complications in the long run. Aflibercept has also been tried in recent trials, and it has been seen that regular injections can sometimes reduce the avascular area, allowing reperfusion of the retina in the long run, which is of course a temporary effect. And once the injections are retracted, there has been seen a worsening of vision also after 1 year or so. That's why important thing is to, if you are managing these patients with anti-VEGF, there needs to be a continuous follow-up and a close watch. So what are the factors holding back against anti-VEGF use in these cases? So number of injections and follow-up visit is always a problem. So some studies have shown that similar results can be attained by quarterly injections or PRN, and of course combining with PRP. And cost effectiveness will also not be a problem very soon with reducing prices and upcoming biosimilars. And risk of systemic adverse events have been safely established in many studies now. There are some practical difficulties with PRP in some cases, that not every eye surgeon has the access to laser machines. Sometimes patient needs referral to tertiary center, and it is of course a time-taking procedure requiring multiple sittings, and sometimes it is discomfort for the patient is too much, and it is difficult to do a good PRP in hazy medias. So this is a case which is a one-eyed patient having NVD, and with following injection there was a reversal in retinopathy. And sometimes injections alone can give such a drastic reversal of proliferation along with management of DME. So take clinic message is that anti-VEGF is definitely first line of treatment in PDRs with DME. And anti-VEGFs also aim to reduce risk of progression of the PDR, preventing DME and vitreous hemorrhage and need for retinal surgeries in the long run. And sometimes it is a very good aid to use it immediately in cases with media opacities. And it should not be aimed, anti-VEGF injection should not be aimed to replace PRPs, but definitely decrease the need or delay the PRP in some cases. And customizing approach considering cost of therapy and patient compliance is important in such cases. Thank you.
Thank you, Dr. Badani. You very convincingly put your points across. Now to counter Dr. Anurag, we have Dr. Saurabh Barma, and his choice of treatment would be laser photocoagulation. So let's listen to him. Dr. Saurabh.
Thank you for having me here. So I'm not allowed to share my presentation right now.
Yeah, I have stopped my sharing now. Sure. So I think you can try again.
Thank you. Is it visible right now?
No.
Doctor, you need to share the button, please.
Yeah, I've shared it.
Just click on the share button. Oh, yes.
Now is it visible?
Yes, just make it into PowerPoint show mode, please.
Yeah.
Yes, now it is visible.
So thank you for having me here. I'll be speaking in favor of panretinal photocoagulation in patients of PDR. According to this relatively recent report, we'll be encountering about 2.3 crore people living with PDR by the year 2045. So it is a massive burden on our healthcare system. And when we are trying to judge a treatment for such a disease, we have to look into ease of administration, cost efficiency, long-term efficacy, and side effects. Of course, giving an anti-VEGF injection is probably easier as compared to PRP, but at the same time, doing a PRP is a part of basic training of any ophthalmologist and is not a very, very difficult task to accomplish. It can be done in patients with poor sugar control and poor ocular hygiene without any risk of endophthalmitis. Now let's look at the outcomes of Protocol S. It told us that yes, ranibizumab resulted in better visual acuity improvement and better preservation of visual field in patients with PDR. Even the development of TRD and need for vitrectomy was lower in patients with ranibizumab. But let's go back to the exclusion criteria of this study. Patients with significant renal disease, poor glycemic control, high blood pressure, pregnant or lactating females, tractional retinal detachment involving macula, evidence of any neovascularization of angle or acute cardiac events were already excluded from the study. And from our own clinical experience, we know that these are the patients who are likely to respond poorly to an anti-VEGF injection as compared to PRP. Then again, about 12 eyes in the anti-VEGF group required PRP due to worsening of the disease, and this happened more so in the second year of the study. So there was an increasing trend of treatment failure in the anti-VEGF group. Again, in the anti-VEGF group, on an average, each eye received about 10 injections in 2 years as compared to 5 injections in the PRP group to manage DME. A cost-benefit analysis was not a part of this study, but if you look at the cost-benefit analysis done at the 5-year follow-up study, about $50,000 was spent on each patient in ranibizumab group per year. So this additional cost was attributed to 2 reasons: high cost of the anti-VEGF injections and high need for a frequent follow-up. In fact, the highest percentage of absence of neovascularization in the ranibizumab group was just 54% at 36 weeks follow-up, and up to 93% of these patients eventually required more ranibizumab injections. So even after treatment success, which was defined as absence of neovascularization for about 3 months, the follow-up protocol would be much, much more stringent in the anti-VEGF group. Now let's look at the 5-year outcomes of the same study. So while the visual acuity improvement was better in the ranibizumab group at the end of 2 years, the visual acuity letter score was almost similar in both the groups at the end of 5 years. So this advantage is gone. DME was slightly lesser in the ranibizumab group, but it was not significantly different. Yes, the visual field loss was significantly lesser in ranibizumab group. But let's again do a deep dive. And this is an analysis of the visual field changes, which showed that the overall difference in the visual field score was actually decreasing. And this was attributed to the fact that despite treatment with anti-VEGF injections, there was progressive formation of new CNP areas, which eventually resulted in loss of visual field even in eyes treated with ranibizumab injections. So even this advantage might not hold if we follow up these patients for another 10 or 15 years. Let's analyze the number of injections that each group received in the later half of the study, that is about 3 years of the 5-year outcome. So in the ranibizumab group, in the last 3 years, each eye received 9.2 injections as compared to just 0.4 injections per eye in the PRP group. In fact, about 42% of the eyes in PRP group never needed any ranibizumab injection in the last 3 years, and just 7% patients required some augmentation of laser to prevent further neovascularization. And as pointed by Dr. Vaibhav Sethi, about 39% of the patients were lost to follow-up. And this was despite DRCR's considerable resources which were put into this study. And this is what we are going to encounter in a real-life scenario. We cannot keep on following these patients every monthly or every 2 monthly if we are treating them with ranibizumab. So anti-VEGF intervention is effective in terms of regressing neovascularization, but frequently it's not a durable therapy. Let's look at the outcomes of the Clarity study. It said that aflibercept was comparable to PRP in PDR, but in addition to other things, it also did a cost-benefit analysis, and it showed that in order to achieve similar visual acuity outcomes, an additional input of about 5,500 euros was required per patient per year. So definitely anti-VEGF therapy is not a cost-effective therapy also. Now let's come to protocol AB, which compared intravitreal aflibercept with vitrectomy and PRP. And yes, 2-year outcomes again showed that the visual acuity outcomes were comparable in both the groups. But the ad hoc analysis did recommend vitrectomy with panretinal photocoagulation over aflibercept because of the reduced risk of recurrent vitreous hemorrhage and requirement of repeat vitrectomy. So all this tells us is that PRP is the way to go. And this is a very important graph from the same study. If you look at the prevalence of neovascularization after 2 years of treatment, the about 24% eyes in the aflibercept group still had neovascularization as compared to about 4% of the eyes in the PRP group. This means that every 1 in 4 patients, despite being treated for 2 years with aflibercept, would still require a monthly follow-up, and this would not be required at all in eyes that had already undergone a PRP. To conclude, anti-VEGF therapy is an important adjuvant in management of PDR. It can be used for treating DME. It can be used for managing neovascularization and vitreous hemorrhage for short duration if PRP cannot be done for some reason. And of course, as an adjuvant before any vitreoretinal surgery, but it is definitely not a substitute of PRP. Thank you.
Thank you, Dr. Saurabh. You very steadfastly supported PRP. And now that we've had this debate, I now request Dr. Sumit Khanduja to step in and finally, give his take on this issue. Dr. Sumit Khanduja is Professor and Head of Department at Kalpana Chawla Government Medical College and Hospital, Karnal. Dr. Khanduja.
Ma'am, for your kind invitation. And at the outset, I congratulate both the speakers for defending their case, and especially Dr. Badhani when most people are staunch believer of ablative therapy. So, ma'am, I feel that you can interpret and apply the results of any study as long as you understand what are the inclusion criteria and exclusion as has been emphasized by Saurabh. So I would say in protocol S, the excluded patients with poor metabolic control, which you rarely get to see in our scenarios. Rather, metabolic control, a good metabolic control is rare to see in my diabetics. Then second issue is that of achieving the monthly injections. Most of our patients, it is very common that they have to miss injections because they have a fluctuating control. Sometimes they are in with the nephrologist for a dialysis. Sometimes they will develop an ischemic heart event, and in those scenarios are the times, or sometimes they're admitted in ICUs. That is the time when the disease actually progresses. So that is why I feel that at least PRP offers a definitive treatment as compared to anti-VEGF injections. Also, for those people who have read the protocol S, I would like to tell that most of the cases that they have included are patients who have neovascular disease without having high risk criteria. Around 70 to 75% of patients, they did not have a high risk criteria. And at least in my practice in India, I rarely encounter those patients who, most of them will come to us, especially if the referral is so poor that most of them will have florid NVDs, NVs, or the first time they encounter an ophthalmologist is when they have a vitreous bleed. So that is one big thing that you have to analyze while reading. Also, they excluded patients with taut hyaloids and ERMs. So one has to understand while they are, applying that study in clinical practice, right? What results they appear statistically significant on paper may not actually be there on the bedside. So I feel that anti-VEGFs have a definite role, but as an adjunct to an ablative therapy, that is laser photocoagulation. And since I do not have a wide field camera, what I have been doing long since my post-graduation days and learned it from my teachers was that in case you see neovascularization is not regressed with the PRP, and which in the best of hands may not regress in about a 1/3 of cases, you do a you do a indirect fluoroscopy, chart out the CNP areas anterior to the equator, and go ahead and do the laser with the pan-retinal lens. So, ma'am, this is my take. Thank you.
Thank you, Dr. Khanduja, for summing it up so well. With that, we move on to our second debate for this session. And in this debate, we've given them a scenario. We've given the speakers a scenario of a well-controlled diabetic who is to undergo cataract surgery. and this patient has diabetic macular edema. So this is again a very common conundrum that is faced by ophthalmologists. Dr. Kshitij would like to treat this diabetic macular edema with anti-VEGF, followed later by cataract surgery. And Dr. Somnath would do cataract surgery along with intravitreal steroid. So first I invite Dr. Kshitij Raizada. Dr. Kshitij Raizada is a vitreoretina, uvea and ROP consultant at the Raizada Eye Center at Bareilly. Over to you, Dr. Kshitij.
Slides visible?
Yes, you can make it full screen.
Thank you, ma'am, for the kind introduction, and thank you, AIOS, for this opportunity. So we have this scenario where we have a well-controlled diabetic with cataract and center involving non-tractional DME of 500 microns thickness. So my approach would be to treat DME first with anti-VEGF, followed later by cataract surgery. DME is a leading cause of vision loss in diabetic patients, and diabetics also commonly come across cataracts which require surgery. So the conundrum arises that should we treat DME first with anti-VEGF, or should cataract surgery come first with or without steroids? To make a decision, we need to understand the pathophysiology of DME. It is basically the vascular endothelial growth factor, which is the primary cause for retinal vascular hyperpermeability during diabetic retinopathy. And it causes fluid leakage, which is because of damaged retinal blood vessels. So the argument for treating DME first is that cataract surgery by itself may exacerbate DME due to post-operative inflammation. And pre-treatment with anti-VEGF stabilizes the retina, reducing the risk of worsening macular edema. So when we treat a patient initially for DME with anti-VEGF, followed later by cataract surgery, we tend to have better post-surgical visual outcomes when the DME is controlled. And as a result, we have a happy patient. Since VEGF is the primary factor for retinal vascular hyperpermeability during diabetic retinopathy, anti-VEGF is now used as the primary therapy for DME. Points in favor of anti-VEGF is that it is directly fighting the pathophysiology for DME. Second, it is very cost effective. With the current price war ensuing between the different pharmaceutical companies, we are now spoiled for choices. We can choose from different molecules. We have bevacizumab, we have ranibizumab, we have the newer generation anti-VEGFs like faricimab and rolosizumab. So the anti-VEGF injections are available in all sorts of price ranges. It is quite easy to administer an anti-VEGF injection. The learning curve is not at all steep. And in today's scenario, most anterior segment surgeons are by themselves administering anti-VEGF injections. As compared to Ozurdex, anti-VEGFs carry a better safety profile. There are very few incidences of IOP spikes after anti-VEGF injection as compared to a steroid implant. Incidences of infection post anti-VEGF are lesser as compared to steroid injections. Ozurdex carries one scenario in which the implant could migrate into the anterior chamber, which is almost non-existent with anti-VEGF injections. As far as post-injection conjunctival hemorrhage is concerned, it is very rarely seen with anti-VEGF injections because they are administered either through an insulin syringe or through a 30 gauge needle, as compared to an Ozurdex, which is administered by a wide bore needle. So points against Ozurdex would be that it is expensive as compared to anti-VEGF agents, and it requires some amount of training to administer because it is given by means of a wide bore needle. So the take-home message would be that the consensus leans towards treating DME first with anti-VEGF to prevent worsening macular edema post-surgery. And we need to tailor the situation as per the patient's need. It needs to be an individualized approach. a patient who has a hard, mature cataract, so in which it precludes any fundus examination. So we are bound to operate the cataract first as compared to treating the DME. But in all other patients where we can get a fair bit of an idea what's exactly going on in the retina of the patient, it's always wise, always prudent to stabilize the retina first, especially if the macular edema is severe. So it's better to treat the DME first and then go in with the cataract surgery. And if the macular edema is mild, then we can even go ahead with a concurrent phacoemulsification with anti-VEGF injection. So that would be my take on this topic. Thank you so much.
Thank you, Dr. Aizada, for those very clear points that you highlighted. And with that, I now invite Dr. Somnath Chakrabarti to counter this. Dr. Somnath Chakrabarti is a vitreoretina consultant at the Retina Institute of Bengal in Siliguri, West Bengal. So Dr. Somnath would be talking about concurrent surgery and the steroid implant.
Good evening, everyone. At the outset, I thank AIOS ARC for giving me this opportunity today. So the case that we have been asked to discuss is a well-controlled diabetic having significant cataract with non-tractional center involving DME and the CMT of 500 microns, something probably like this. It's not very uncommon in our day-to-day practice also. And I have been asked, how will I manage and why? So my answer would be that I would like to do a cataract surgery with a DEX implant given at the time of the surgery or just prior to it. And let me share with you the reasons for the same. But before going any further, I'd like to, of course, make it clear that there are no financial disclosures that I need to make, that I would have to share or before presenting. So as probably would be very clear by now, because almost all the topics have been so beautifully covered regarding diabetic retinopathy, that DME with cataract is a challenge. The reason is the cataract surgery can worsen diabetic macular edema. Now, this is not only for pre-existing DME. That means you have a DME patient with DME and cataract. The DME is still there. Not only will that be worsened, but even if you have actually treated and resolved the DME, 2/3 of these patients after cataract can have a relapse. And we have had few cases discussed today itself, in the evening itself, of patients who had cataracts 4 months before and then, had a relapse of DME. So why does this happen? And the single word answer for that would be inflammation. So we know cataract extraction leads to breakdown of blood ocular barriers. And in this enhanced intraocular inflammatory response is the key driver behind this worsening of DME. So then the question is, how do we solve this conundrum? As ma'am said, this is the correct word. This is actually a conundrum. So one is that we keep delaying the cataract surgery as long as possible. But I think all of us would agree here that that is not the best approach, because as the cataract matures, as Dr. Kshitij has also so beautifully pointed out, that the assessment of the retina itself becomes difficult. So we'll definitely not want to delay the cataract surgery unnecessarily. The second, therefore, approach, and which seems more sensible, is that we blunt the inflammatory response, which is the root cause of the worsening of the DME. And how can we do that? One is either we use anti-VEGF or we use steroids. And amongst the steroid, we have two choices. Either we use an intravitreal triamcinolone or a DEX implant. Now, Dr. Kshitij has already suggested why he would want to prefer an anti-VEGF. But I would love to say that, because it's an inflammation which is driving the process, it seems more the common sense approach, which is right now, the global keyword probably, the common sense approach, that we use an anti-inflammatory agent like a steroid rather than anti-VEGF to handle this scenario. Amongst the steroid, I would prefer the DEX implant simply because it has a 6 times higher anti-inflammatory action than the triamcinolone. Plus, it has a sustained action for 4 to 6 months, at least 3 to 4 months even in the real world, which means that it will not only take care of the pre-existing DME, but also the post-surgical inflammation-induced worsening of the macular edema. So, in the case that I showed in the first slide, so this was a patient. This is, say, a non-tractional center involving DME with cataract. So we do a phaco-IOL with a Ozurdex injection. This is after 2 months. You can see beautiful resolution of the center involving DME. Usually, now this is after 3-4 months, we can expect some recurrence, but in this case, even at 4 months, there was no recurrence of the edema. But by 8 months, you can now see the edema is coming back, at which point we have repeated the Ozurdex. So just see 2 injections, and you have covered, at least in the first 6 months, you have just taken 1 injection, and with 2 injections, you are almost going to cover an year. But then you may say that this is a rare case. You may have just a single case like this. But then I like to share with you that last year we published this study in clinical ophthalmology, where we had a retrospective analysis from our institute of 20 cases of treatment-naive DME patients with cataract who were treated by first giving an Ozurdex injection and then doing a phacosurgery. Now, of the 20 cases, 15 had mild to moderate NPDR, 3 had severe NPDR, and 2 had PDR. In all the patients, we had visual acuity gain of more than 3 or more lines. This is with 6 months follow-up. In all the patients, we had significant decrease in central macular thickness, which was sustained through 90, that means at a 3rd month as well as 6th month follow-up period. Only one case had a central subfoveal thickness more than 300 micron at 6 months. Now, one fear with steroids is that there will be a secondary IOP elevation, something that was pointed out during the discussion on how do we treat DME, what are the options. But as has been seen repeatedly in real world, this is actually not so common. And even if there is an IOP elevation, it is mostly transient. So was our experience. Only 2 cases had IOP elevation, both of whom could be easily managed with topical medication. But the most important thing, 3/4 of the patients did not repeat an injection. Now imagine you treat a patient with anti-VEGF, you reduce the edema, you do a phacosurgery, then you have a relapse, and you are again putting him on injections, as has been again discussed repeatedly, in the debates before also, that anti-VEGF injections, once you keep repeating them, then the cost really becomes huge. Now, if you can, however, manage this with an injection which might be expensive but doesn't need to be repeated so often, maybe in the long term, the costs balance out. So in our experience, only 5 cases, that is 1/4 of the cases, required a second repeat injection, typically around the 3rd month. And these were mostly those cases who had more severe DR. So as you can see, 1 case of the severe in PDR and both the cases of PDR fell in this group. So for a moderate NPDR or mild NPDR with DME cataract, you can expect that even a single injection may be enough. So based on our data, we concluded in the study also that diabetic macular edema, that Ozurdex in a patient of cataract with DME not only helps manage the pre-existing DME, but also reduces post-surgical inflammation induced as worsening of the DME. So if I have a case of cataract with DME today, I will definitely, and if the cataract is significant, I will definitely not want to delay. I think all of us will agree on that. Now, I will also not try to first give injections to reduce the DME and then treat, because I know that even if I successfully resolve the DME, there is a chance that 2/3 of these patients will have a recurrence post-cataract. Dex implant, however, can take care of both these, the pre-existing DME as well as the post-op or worsening. Therefore, in my mind, it seems that it will be a good option to consider. And IOP elevation, which might be a factor which may hold you back from choosing a steroid, is in the real world not such a big factor, and mostly it is transient and easily manageable. So thank you so much for the patient hearing. Thank you.
Thank you, Dr. Somnath. I think both the speakers have very well defended their viewpoints. And now I ask Dr. Kopal Mittal to step in. Dr. Kopal is a VR and ROP and UVR consultant at the Sandeep Mittal Advanced Center at Meerut. And she will be giving her take on this topic.
Thank you, Dr. Tinku, and thank you, AISARC, for this opportunity. And I would like to bring about, there are 2 aspects to be discussed in this debate. When there is an existing diabetic macular edema with a planned cataract surgery, one is to pre-treat or treat, and the second is what drug to use. So I'm a big fan of pre-treat diabetic macular edema rather than make it an unpredictable bet that whether the drug will work or not. As we know, there are non-responders of DME in both anti-VEGFs and steroids. So as Dr. Kshitij said, it's a must that we pre-treat and we look at the response before we go in for the cataract surgery. But yes, the disadvantage is that with anti-VEGFs, you need repeated injections if you're pre-treating at the time of the surgery and then later on again, even up to 3 or 6 months post-cataract surgery, as resolved macular edema patients post-cataract surgery may develop diabetic macular edema as late as 3 months. And being such a demanding procedure, cataract surgery currently warrants that we need to give more predictable outcomes. So there comes the take of which drug. So if there is a pre-existing macular edema with biomarkers of chronicity like hyperreflective foci or neurosensitivity, then it's a must that we use a longer-acting depot steroid. And yes, a Tricot not being a very reliable and approved drug, if the patient is affording for a DEX implant, that would be the best bet. Otherwise, repeated anti-VEGFs, according to the respecting to the pocket of the patient, may be required for the success of cataract surgery. But definitely pre-treating the diabetic macular edema and knowing whether the patient is responding before the cataract surgery comes in is the way to go. The drug choice would depend on whether we're going to really kill an ant with an atom bomb or is it a long-standing and chronic to stay macular edema. So there are two parts of this debate. That's my take on it, Dr. Tinku.
Thank you, Dr. Gopal, for wrapping it up so nicely. Thank you so much. So I thank all the people who took part in the debate. I'm so sorry we've really overshot the time limit, but I think so much information was shared in this webinar that this was bound to happen. And with this, we come to our final and concluding section called Saransh. So Saransh is a section that we have in every monthly webinar of the ARC. And in Saransh, we invite an eminent speaker to give you the gist of recent journal articles that would be relevant to everyday practice. And this evening, we have with us Dr. Brijesh Thakkar. Dr. Thakkar, first of all, my apologies for having kept you so long. So, Dr. Thakkar is a vitreoretina consultant at the LV Prasad Eye Institute, Hyderabad. He has done extensive research in diabetic retinopathy and has multiple presentations and publications to his credit. And not only is he an academician, he's also a researcher. And I think he's just the right person to give us a summary of the recent journal articles and some pearls that we could gather from these articles. So over to you, Dr. Thakkar.
So thank you, Tinku and Team ARC. I hope I'm audible and visible.
Yes.
And, since I'm doing it at the end, it's my job to keep everybody awake also. So you asked me to talk about something which is hot and sizzling, and I thought what better than a meta-analysis. And the one that I intend to discuss is something which has just come out this month in a journal by American Academy, and it will actually cover both the debates which just happened few moments back. So this is about anti-VEGF injections or PRP lasers for PDR. And we are also going to look at how we take care of macular edema in these patients. So the authors have actually taken up around 19 randomized controlled trials. They went through the PRISMA guidelines and took care of the biasing elements and came out with the degree of bias present as per the recommended methodology. So just to show that this was done in a very good and scientific manner. So the first result that I would like to discuss over here is monotherapy of anti-VEGF versus PRP in terms of what the patient gains for their visual acuity. And the early term result represents 1 month, mid-term represents 6, and long-term represents 12 months. You look at these confidence intervals of these odd ratios, and we realize that in the early period, the anti-VEGF seems to have slightly good amount of visual acuity for our patients, although the letters gains are very few in terms of their biological relevance. However, once you look at the long term, we realize that the odds ratio confidence intervals are right crossing across zero. And it basically means that there is no advantage in terms of visual acuity with monotherapy with anti-VEGF as compared to PRP. However, once we start looking at combination therapy of PRP plus anti-VEGF versus only PRP in terms of visual acuity, we realize that in the long term, there is slight advantage of combination therapy which can give our patients better visual acuity scores with 4 ETDRS letters. Although the lower confidence bound is, it's very close to 0, but there is slight advantage with combination therapy for PDR. Breaking down these results further, looking at the macular thickness, the authors pointed out that if you look at this, this is the very early term, mid-term, long-term. Look at the letters gain, and we realize that slowly whatever advantage was there for the decrease in macular edema vanishes in the long term. So it seems that there is not much advantage in terms of macular edema with while using anti-VEGF in combination in patients who have both PDR and DME. As far as regression of new vessels is concerned, the new vessel regression with monotherapy with anti-VEGF as compared to PRP, it was seen that more patients with PRP had regression of new vessels. This is partial regression of new vessels. But once you want a total and complete regression, we saw that this was more commonly seen with those who used anti-VEGF. So this is something like an equivocal result, and not much came out in this regards. And similarly, for combination therapy of anti-VEGF plus PRP versus only PRP for new vessels, we found that the odds ratio was sticking all across the one line, which means that there is no good statistical evidence to suggest that there is any advantage of using combination therapy for regression of new vessels. So these conclusions are the ones which have been put forward by the authors themselves. These are not my words. And after a decade of research and so many research discussed by Anurag, then Sharath, then Dr. Lalit, then Dr. Munna and Vaibhav also, we still read this word that it could be used as an alternative approach. And what we should do is that we should make a shared decision making with patients on the basis of patients' adherence, their macular edema status, and their preference. So this said that patient's DME status actually probably plays, a lot of should be given a lot of focus. Why? Because this was the only factor which controlled the visual acuity gain in long term in these patients. And the other thing which the authors concluded in this actually very nice meta-analysis was that continuous injections and monitoring is required. And this adds to burden to everybody, not only to patients, it adds to our burden also. And in the end, they more or less get the similar results. Now, all this said and done, the American Academy of Ophthalmology still recommends PRP specifically for high-risk PDR populations. This is what Sumit was saying a while ago, that all these trials have included certain kind of patients and not certain kind of patients. And if you look at our publications, we realize that we end up seeing more of HRC PDRs, and now that's a problem for us. And then this long term, what is long term? So long term in this particular meta-analysis was just 1 year. Is that long term enough? So these are certain questions which we are facing right now in our society. But what we need to understand is that DME status perhaps indicates that we should go for combination therapy approach for these patients. So I gave something which was hot and sizzling in my opinion. I also thought that something like a dessert should be given to our general ophthalmologist. And so I came up with this a newer approach to diabetic retinopathy. So this approach is actually trying to curtail progression of NPDR to PDR or to DME. Basically, not to let our patients of DM go to sight-threatening disease stages. And this ASCENT study is actually a trial done in cardiovascular patients, giving them omega fatty acids and seeing what happens to their cardiovascular events. However, one report published in ophthalmology talks about what happens to patients who have DM, whether they develop referable DR or not. This is a Kaplan-Meier analysis, and what we realize is that both the curves of the placebo and the treated arms are actually reaching at the same levels. So actually, there was no benefit of giving them omega fatty acids. Similarly, the odds ratio were actually more favorable towards the placebo rather than the drug, although the biological significance is like 1.25, it's not much. So apparently there was no benefit of giving people with DM omega fatty acids to prevent development of sight-threatening disease, diabetic retinopathy. However, there is another trial which has come up in last year. Now this is published in NEGM Evidence, and it talks about using fenofibrate to prevent progression of DR in people with DM who had minimal DR or no DR at all in the beginning. Now this is the Kaplan-Meier survival analysis, and it talks of the hazard ratio. And as soon as after the year 1 of therapy with fenofibrate, we see that both the curves are separating and they maintain this separation right till the end of 4 years. The hazards ratio for if we give patients fenofibrate is 0.73. So apparently there is an advantage and we can actually prevent our patients developing PDR or DME and requiring all those kind of therapies and follow-up. However, this comes at a cost because a deeper dive in this paper, I found that their kidney disease had started to increase when he gave them fenofibrate. So what does this mean to us? It means to us that there are certain therapies which are going to come in the near future, and they can be utilized by the general ophthalmologist to prevent progression of DR also. When once a patient of DM comes to you and you start giving them some therapy, they are going to be more compliant to your follow-up also. This somewhat answers the question raised by Dr. Muna right in the first discussion itself, that our patients don't come back at all and they don't even tell that they have DM. So this is something which has to be done by the general ophthalmologist, not the tertiary level retina care centers. So these are the two papers I thought I should discuss today.
Thank you, Dr. Brijesh. Those were some very interesting articles. And I just noticed in the end, there was another article that you had published on unconventional methods to decelerate diabetic retinopathy. Could you talk a bit about that also? What are those unconventional methods?
So we have been working at 4 or 5 approaches, Tinku, to delay progression of diabetic retinopathy. These approaches either look at the gut microbiome, or they look at antioxidants, or they look at neuroprotection, or they look at anti-inflammatory agents. So you can say that we are in an exploratory stage only yet, but it's a huge sample size, and we have submitted our first paper, but we should not shout till the time things are published. But the point is that we are in a stage where we can actually stop people from losing vision.
Yes.
With cheap, non-invasive therapy which can be tolerated forever. That is the point which I wanted to make.
True. So in your practice, do you give these fenofibrates to the patients, or even
No, not
statins?
fenofibrates. Fenofibrates are actually approved in Australia. They are approved in certain countries. But as I said, that while we are saying that these people had normal vision to begin with, their vision stays normal if you treat them, but their kidney function starts deteriorating. So what are we giving to the patients? So not fenofibrates, but certain other therapies, fingers crossed, they will come out.
Okay. Thank you. So with that, we come to the end of this webinar. I think we've had some very interesting discussions. Some very good practical pearls were shared by all the speakers. My apologies again to everyone, so that we've really overshot the time duration. So with that, I thank our chairpersons, the discussants, the speakers, and the audience who've been with us this evening. I'd again like to share with you that this webinar is available on the AIOS website, on the YouTube channel, and also the Facebook page. So for people who had logged out early, they can go back and refer to this webinar at leisure. So with that, thank you so much. I hope it has been a very educative and enlightening webinar for all our general ophthalmologists. And thank you all for your presence. Good night. Good night.